Hello.
Hi, how are you?
Good, you?
Good, thank you. It's Sheila. Sorry I logged in late. I forgot I was registering.
No problem.
My daughter's registering for CEGEP and I was like,
Oh,
God, it's 1:30.
oh, that's for courses, huh?
Yes.
It's always, it used to be a rush, like everyone wanted that course and it's
Well, it's
hectic.
crazy. This is the first time, we're doing it. So but I was like, okay, it's 1:30, get off, I need it. So, yeah. I made you co-host. I'm going to, obviously I won't be back on at around 3:15, I guess, to see if Julien's on, and then I'll give him co-hosting duties as well.
Okay.
All right, so there's 9 participants now. Usually there's at least 20 to 25, but it's recorded, so really whenever you feel free to start whenever it is you like.
Okay, and now this is just us talking privately, and when you stop this, I'm gonna be talking.
No, honestly, I don't know if this is everybody might be listening to us. I'm not quite sure. Zoom is all still kind of new. I think everybody can hear us.
Yes, we can hear you.
Oh, hello,
there
guys.
We go. So now, you're good to go and you're ready to share your screens whenever you want.
Okay.
You're good. All right. Thanks so much, Joanna.
Thank you, Sheila.
Have a good day.
Hello, everyone. So this is my first time hosting something. Everyone can hear me, I assume. If not, write it down. And let's see, share screen. This one.
Excellent. We can hear you and we can see your screen.
Okay. So can you guys turn on your cameras? Whoever is not like on a computer hospital and can do it, just so I can see who's there. Let's see. I'm so new to this. Participants 12. I know Shafiq is in general surgery. Who else wants to introduce themselves? Which specialties are you guys from? Hello. Now I get it when like my attendings give us classes and they're like, hello, who's here? Anyone? Chat. Neurosurgery, okay. Al-Mansouri, Abdullah Rahman is from neurosurgery, but you can talk, guys, you can talk because I'm gonna be asking questions. Okay, 2 neurosurgery people. Anyone else? What about Alexandre? Which specialty are you in? Okay, ortho.
OBGYN.
Okay. Okay, Joshua, you're from where? Salim is from Gen Surge. Good luck, my friend. Ria, Joshua, where are you guys from?
OBGYN.
Oh, okay, that was you. Okay, I can't see who's talking. Plastics, then for Yasser. And Al Shamari, we have an Al Shamari in urology. Are you connected to our Ahmed? Yes, I won't know. So I will start with a presentation that is about how we hand over patient care. It's based a little bit on my own experience as a junior. Sometimes I was under the impression that things could be done better. I had some great experiences, I had some bad experiences, and I'm just hoping to give this class so that we hand over patient care in a safe way. So anyone has an idea of how many times like patient care gets handed over in a day, for instance, in Gen Surge? Like
twice.
Yeah, twice. So that means that in a week that patients will get handed over 14 times. Okay, maybe sometimes the same people will come back, but that's 14 like residents. And then sometimes depending on the hospitals, the staff also changes. So that can be maybe 7 different staff as well. So that gives us 21 people. And then we also have nurses and nurses who hand over patient care. So that gives, like, I don't know, another 40 people. So that's, if we imagine how many people just talk about the patient without necessarily having seen the patient that particular shift, that's like a huge number of people who talk about someone. So we better relay the proper information, because it can create, like, it has huge potential for miscommunication. So that is the beginning of my presentation. And I don't know if I introduced myself, but I'm a resident in urology, and yeah, I'm still a junior just like you guys. Let me try to get this off my screen. Okay. So that's a lot of handovers in a day. And if we take an example, a neurosurgery example, you have a 22-year-old who comes in and he has a neck injury and he's neurologically intact, but he has a C6 fracture and a C6, C7 subluxation with anterolisthesis. Apparently you're supposed to take this to OR. I did not know this before I did my trauma rotation, but yeah, you take this to OR for fixation. And then a neurosurgery usually wants to follow up on the repair. So they requested a CT scan on post-op day 3. So you're the resident on call who will take this patient, and there's a CT scan that gets done on the Friday afternoon. And there's a report, it's like a preliminary report, and the finding is hidden, like it's hidden somewhere in the middle of the report, as significant findings are usually hidden. And it says pedicle screws are not positioned correctly and appear to be transecting the vertebral arteries. Now that seems to be quite a major finding, but radiology does not manage to reach the neurosurgical team, the neurosurgical resident on call that night. So there's no communication of this finding. So then you get the handover from a Friday to Saturday, and your colleague tells you that, yeah, there's a patient that got a CT scan and that he can probably get discharged the following day once the CT scan is done. But per se, there's no relaying of the information that you know, did the previous resident check the scan or not? That's not mentioned. So the on-call resident assumes that his colleague has reviewed the image and he discharges the patient the following day, as he was told that this was the plan for this patient. So what happens after is that the patient comes back a few days later with right-sided hemiparesis, which he did not have on his initial presentation, diplopia and ataxia, and the angiogram reveals that one of the screws has injured a vertebral artery, causing the patient to have a stroke. So I will take your suggestions for what you, well, first of all, what do you think about this scenario and how could we have avoided it? And I will go and have a look here. Participants. So who was in neurosurgery? You will be the victims. Chat. Such an old lady. Abdullah Rahman, what could we have done to avoid this outcome? Better handover, yeah. Okay, how do we do better handover? Anyone can answer with your mic. It's easier for me because I can't really see the chat if I'm presenting. Ashley, do you have any ideas how we could have better relayed the information in this case?
So in terms of like better handover, like making sure that you're doing face-to-face communication, that you're sitting down and like talking to the person and making sure that like all this is being communicated in a way that they're understanding the gravity of the situation.
Yeah, it's very good. Face-to-face handover is a very important point. Thank you for that.
And then also even just like with writing progress notes in the chart, making sure that you rate those details in if you think it's significant for someone to know, if someone happens to read the chart too.
Yeah, that's another thing that we don't do very well actually here at McGill. I find charting. What specialty are you in?
Obstetrics.
Oh, okay, great. So yeah, we don't chart very well, and that's indeed like if we plan on getting a CT scan before discharging someone, and the CT scan is a limiting factor in the sense that we need it to be clean to be able to send the patient home, then it should definitely be documented that, okay, CT scan obtained, results seen, no finding. And usually we should base a discharge of someone like this patient on a final read from a staff. If there are any significant findings, you know, like this one was read by a on-call resident, you should definitely communicate with the staff or a fellow in radiology to correlate the findings if you have any concern in the sense that you don't think this is there. And wait for a final read from an attending before sending someone home. Because maybe the on-call resident is a junior and he doesn't have enough experience and he misses on an important detail. So yeah, if we decided that we're getting the CT scan so that we send the patient home afterwards, then we need to document that we got it and that it is clean. Anyone has any other suggestions? That was good. Thank you, Ashley. I shall be targeting someone else. Sarah? Or anyone? Alexandre? You're not there?
Yeah, so I think like what Ashley said about sitting down and having a face-to-face conversation is important, but also maybe like, you know, communicating that finding with the whole team. So whoever's involved in patient care, like the nurses, as long as everyone's involved and is aware of any sort of major findings, I think that's important.
Mm-hmm. But how could we have, like, what's the part of who's responsible in this situation for not communicating that? Is it the person who was on call and who handed over, oh, I'm waiting for this CT scan? Is it the other resident who didn't check that CT? Is it the radiologist who didn't call the neurosurgical team? Whose fault is it?
Well, I don't think it's any one person's fault. Everyone has like a part to play. It's just an accumulation of like missed opportunities that leads to these outcomes.
Exactly. So it's everything went wrong in this case. Everything that could have gone wrong went wrong, and that's how it will happen also for you guys. When something goes wrong, it will be on all the possible levels. Thank you. Okay, so the factors that impact the quality of our handover are usually multiple, but there are some things, you know, some easy things that we can fix and some other things that are a bit more difficult. So one of the easy things to fix is the setting. This was mentioned, face-to-face handover should always be the standard. Never text or email handover alone. You can text or do email handover, you know, for further details, or I don't know, for things that are adding on top of a patient that was already signed over verbally. So at least face-to-face, if really impossible, phone sign over is fine. The reason why phone and face-to-face are preferred is that it gives the opportunity for both parties to ask each other questions. So I don't know, the resident who took the call for that neurosurgical patient, maybe if they would have done a face-to-face handover, he would have been able to ask, okay, did you look at the CT before discharge, or do I have to follow up on the results? So face-to-face or phone allows for questions, and questions really allow for a proper handover. The setting needs to be quiet. If most of you will do an ICU rotation, you will realize that as you're trying to hand over to your colleague, 30 nurses will come to see you for a laxative that was not re-prescribed, and suddenly it becomes a national emergency at, I don't know, 8 p.m. You have to learn how to deal, with the urgent things that may interrupt your handover and the non-urgent things that should not. So you can advise your colleague nurses that, we're doing handover, we will be addressing X issue within an hour or later on during the night or the day, as we're just trying to do a safe handover of the patient. So minimizing interruptions is also a great way, because if you're trying to focus and then someone keeps interrupting, it's not really going to allow you to get an idea of the patients that you're taking care of. And at night, especially for people who get handover for the night shifts, so like in Gen Surg, when you do it at the VIC, you cover HPB, you cover what else? You cover ACS, and you cover all the post-op patients, all the floor patients. So you cover consults for like 2 services, and you cover probably 2 floors. So you may end up getting handover for 30, 40 patients. And you won't be able to see all of these patients at night. So you need to listen to your colleague and take good notes. Time constraints. So if you're a junior and you get handover from your R5, your R5 will give you a very short handover. She's going to be, oh, you need to follow up this CT. Okay, as a junior, you need to ask all the questions that you would ask another junior and not really feel intimidated by any difference in like status. So why are we getting the CT? Why am I following up on it? What do I have to look for? These are not stupid questions. These are very important questions to ask. So don't rush. And if your senior needs to leave for journal club, then that doesn't really matter. You guys should plan for adequate time before he needs to leave. So don't give yourself 5 minutes for a handover. It's not gonna help you have a good call shift. If you get a 5-minute speech on about 40 patients, you will be lost and you won't have enough information on your patient. So plan ahead. If someone needs to leave, just plan accordingly and get handover at that moment. At this point, does anyone have any other suggestions on factors that could influence the quality of handover? I saw there's a Paul in the list. Hi, Paul. Hi. What specialty are you in?
Sorry, what was that?
What specialty are you in?
Orthopedics.
Orthopedics. Nice. Congratulations.
Yeah.
Do you have any ideas of factors that can improve the quality of handover? We talked about setting and time constraints. Anything.
Time constraints, setting.
And also you guys usually have huge lists because you do consults and you end up having huge lists of
I think quality of handover, now we've kind of implemented List Runner. I think that's helped the quality because it keeps everything organized a lot better versus just printing off a list and expecting to know the patients offhand.
Yeah, so that's a good thing. And keeping that list updated also matters, because if it's a list that was last updated 2 days ago, then no bueno. So yeah, that's a good thing. So keeping the list updated for the day team. And also once you have completed your call, it will greatly help your colleagues, because all of the details that you will not mention verbally may be found potentially in the list, and spare someone, I don't know, having to go back on the floor to check on how much heparin they are, or if they got anticoagulation before their OR. Very good. Thank you, Paul.
No problem.
So missing information also goes along with what we were just mentioning. So don't hesitate to ask questions, and you can be annoying and ask, did you see the labs? Did you see the CT? Did you call ortho about this about this patient in ER that seems to have a compartment syndrome? Like, do they know that they have a consult? If you're ICU, for instance. So don't hesitate to ask for these things. If you have a patient in the ICU or in ortho or on trauma, and you just got the patient, they were in an MVC, for some reason they go up to the floor, they don't have to stay necessarily in the ICU, you should try to get an idea of the baseline of that patient, especially if you know that they have anything intracranially. So ask, what was the Glasgow today, or what was the Glasgow on arrival? Because when the nurses call you and tell you, oh, Glasgow is 8, the Glasgow was 9 before, and if they have a Glasgow of 8, they should be in the ICU. If the Glasgow was 9 and they just went to an 8, okay, there's room for like observing, there's room for just seeing if you can decrease the sedation. But if the Glasgow was 15 and it goes to 8, then that completely changes the game for us. So don't hesitate to get an idea of the baseline of your patients. Then communication style. So signing out to seniors may be intimidating. Different staff or different residents may have different approaches to a case. And as long as, all the labs are done, all the tests that need to be done are done, that should not necessarily impact the quality of a handover. When you listen to people give you handover, take it as a learning opportunity. You can learn a lot from how they approach a particular problem, how they work up things, how they work up sepsis. So ask them, what labs did you order on arrival? And that's not to judge what they did, it's just so that you can learn for that moment when it will be your turn to admit that patient. And non-structured approaches, this goes with what Paul was saying, having something structured like a list runner, Google Drive, whatever, but it needs to be structured and it needs to be updated. And even when you give sign out verbally, you should have a structured approach. You say 54-year-old male, right? You give the ID, then you say admitted for, I don't know, post-op lap chole. So you need to mention why the patient was initially admitted, because that's another type of information that gets often lost, especially for patients who have been admitted for 100 days. They get handed over and we forget in the handover why they were initially admitted. So I wanted to do an example of an ICU handover, if that would interest you guys. So ICU handovers can be quite complex because the patients have usually very long comorbidity lists. So you can make it simple. So this is the one-liner I was mentioning. Mr. Proteus is a 51-year-old, a male admitted this afternoon with urosepsis. Bam. That is a lot of precious information you just gave to someone, and it may sound silly, but we forget sometimes to even give this one-liner. So most important, one-liner. Then the pertinent medical history. We are not internal medicine. I respect our colleagues a lot in internal medicine, but when we hand over, we don't need to know that the patient had a broken left toe in 72. Okay, so we just need to know, okay, he's cabbage, recent, and he has type 2 diabetes. And that's important because we know that this may impact the outcome of the sepsis. And we also know that we need to check, when I get handover for someone like that, I know that if the nurses call me for chest pain, I will be ordering EKG tropes very fast. I know that if he has insulin dependent diabetes, I need to check, you know, his glucose. I need to check if an insulin scale was done by my colleague or ask if they did one. But I don't need to know about the hip arthroplasty or all of these things, okay? Then reason for admission. And now when you give an ICU handover, you need to detail a bit more reason for admission in the ICU, because urosepsis can also go to a floor. So why did we specifically take that patient in the ICU? Okay, he was hypotensive 70/50. So that's a pretty good reason to be in the ICU. And desaturation to 80%. And then you need to tell your colleague what you did to fix those two big issues. So cardiovascular, okay, so we gave 3 boluses in Emerge. He got 1 transfusion. He responded well after the boluses. His BP was 90/60. So that's very short, but it tells you a lot. The patient is responsive to fluids. That's a good sign, you know, in terms of managing a sepsis. Resp-wise, we intubated in the ER. The airway team was there because of COVID precautions. Anesthesia reported no issues with the intubation. Okay, so that's good. After the intubation, he got a CT chest abdo-pelv, which revealed, you know, a 9mm stone. So that's how we found out that he has hydronephrosis, and he had got the urine analysis and urine culture, and it's already positive. And you're also saying to your colleague, okay, we gave Tazo-Vanco, you need to monitor labs. Usually when we have someone like sick as this patient, when you get handover for this type of patient, you should ask, okay, how often should I be checking the VBG? How often should I be checking the lactates? Because if a patient has a pH of 7.1 and lactates of 8, you should give more fluids, and you should definitely repeat those labs at least Q4 until they improve significantly. And then you need to think, if you're a service like ICU or trauma, you need to think if you need to bring in consultants, and not so as to avoid harassing them. You should communicate, you know, did we already establish contact with ortho, urology, gynae, whoever needs to come and take the patient to OR. And then a few tips for you guys. If you get a handover for a patient, you should ask your colleague, you know, the staff we're working with tonight, does he want to be called? Does he want to be texted? Can you give me his number? Can you give me his spectrum? And ask, do you think you forgot to do anything in terms of orders? Again, not to judge, but just so it gets done before it's too late. Oh, I forgot to adjust the Tazo dose for his creatinine function. Because I hope you know, you need to adjust some antibiotic doses to renal function. So just try thinking ahead, ask questions, and at first the few handovers that you'll be getting will be maybe a bit longer, but it's always better to have a longer handover than a shorter one. And here are a few tips and tricks for the services that you may be rotating on. So if you are doing ACS at the MGH, you will need to type a long email with all the patients that you had under your care during the week, and just say, not the specifics like the labs, like I mentioned for that ICU handover example, but more, why was the patient admitted on ACS, and what does the new resident that will be taking care of that patient for the following week need to know. So you will do one email handover, and you need to CC the staff on that email and your new co-resident, and then you will also be doing phone handover. So that's like a double handover. And I guess if the service has lots of patients, it's always good to get like a written email, but it's a bit repetitive with the list. Unfortunately, the staff at the MGH are used to this way of functioning, so I doubt that it will change during your year. So be ready on Saturday or Sunday when you rotate on ACS at the MGH to type an email handover and CC the staff and your new co-resident. Then for Gen Surge at the MGH and RVH for the day and night handovers, it's usually very early in the morning. It can be anywhere between 5:15, 5:45 for the trauma service or the Gen Surge one. And in the afternoon, sometimes it's around 6, sometimes around 6:30. It really depends on how the day goes. And for the ICU handover, it's usually at 8 a.m. and 8 p.m. And plan on arriving maybe at 7:30 to get handover and do a quick eyeball round on your patients. Also for ICU handovers, for those of you who will be rotating on ICU, walking rounds, like literally going room by room with the new resident that will be taking care of patients at night, is an easy way to do rounds, because this way both of you can see the patient, and it's so much faster than like running the list and explaining everything. Like you can visually see, oh, the patient has a central line, and then if you're taking over that patient, you have visualized it and it helps you memorize. So walking rounds are a great way to do a handover in the ICU. If you have this opportunity, I suggest you take it, because it's gonna simplify everything for everyone. Does anyone have any questions pertaining to handover? Anything can also be related to how the services function in terms of like what time you're supposed to come or anything like that. Participants, let me see the chat. Okay, there are no questions in the chat, and I will be following with my next presentation. Which will be a few tips and tricks for surviving and troubleshooting stuff on the wards. So I would like to know what scares you guys the most as you start, as you have started rotating on your services, in terms of the ward. Is it getting an MI on the ward? Is it having a code? What scares you? I will be picking people. Simon Martel, vascular surgery. And then, yes.
Yeah, so I was actually on call all weekend, and I had a patient crash on me. He sat to 70%, and thankfully I kind of knew the cause. It was pulmonary edema, because we had transfused him 2 units in the morning. But if I didn't really know the cause and I had a patient crash on me, no senior coverage, I would be pretty scared.
Wow, yeah. Are you an ortho resident doing vascular?
Exactly.
Oh, we saw each other at the CAF.
Yes, we did.
Yeah, status epilepticus. Yeah, that would scare me too as well. Abdullah Rahman. So yeah, having someone desat and then you realize that you you don't know why they're desatting is horrible. Sometimes you have a cause, like patients that are in CHF and they start desatting and they're just like desatting by 2%. You're chill because you know what's the most likely cause, but when you have no idea why they're desatting, that can be quite stressful indeed. So there's a systematic approach to these things, but the answer is that when you have a scary situation, call a code or call a senior if it's not a code situation. So let's go. Before we get into like the management of the scary things, how to come prepared to your ward rotations. Let me just get this. So get a good quality handover. I just did a 20-minute crash course on that. Arrive early, check the morning vital signs in the labs, and do not neglect what the vital signs are telling you. I have heard rumors that sometimes in ortho, the vital signs don't get checked, and that there's a belief that the nurses will call you if there's something wrong with the vitals. That is false. The nurses will not call you for abnormal vitals unless it's like a saturation of 70%. But I have had colleagues who did not get called for saturations of 80%, and colleagues who did not get called for like, I don't know, AFib running at 150. So don't assume that you will get a call for every abnormal vital. And I find that vitals speak a lot about the general condition of the patient. So I think it's worth checking them. No offense, ortho, but that's what the rumor says, that you guys don't check the vitals. If you are rounding on a service alone, like what happened to Simon, or what will happen to most of you when you will do Gen Surg at the MGH, Gen Surg, I'm sorry, I meant ACS, then you have to determine who you will see first, because some patients will be sicker than others, so you need to determine who needs to be seen first, and sort of be efficient about the way you're rounding alone. If you count on the help of medical students, which we all were not too long ago, then you need to think of how you would want to be involved if you were them. So they're not note takers. They can write notes, but they're not scribes either. So try to get them involved as much as they can get involved, but don't treat them like secretaries, because that's not what they are. They are medical students, and they're there to learn, just like you were there to learn, a year ago. So so I would not necessarily let the medical students let them write, the boring notes for chronic patients, and I would always read their notes and countersign them, and I don't know, give a few tips on how one can make the notes better. When it comes to notes, don't forget to write an impression in a plan. That's important. Sometimes we just write continuous pain management, but it's worth, taking 2 seconds to write small bowel obstruction, resolving, continuous pain management. That helps nursing know why the patient is admitted. That helps physio know why the patient is admitted, and that just improves communication. So don't forget to write impression plan. And prepare discharge summary in the OR. When you're, I don't know, if you're scrubbing in for a case and the nurses are putting the Foley in and it's too late for you to go see a patient in Emerge, take that 2-minute period to start the DC summary in the OR instead of having to do it, at 7 p.m. at night. So learn to optimize your time so that you can also optimize your exposure. And then you will also need to learn how to negotiate with patients. You will frequently get requests, for, can I go smoke outside? And the patient is like, I don't know, tachycardic, and they are there for a pneumothorax. I have had this while rotating on trauma. Ideally, sir, you should not be going outside for a smoke with your chest tube. But yeah, so you will need to learn how to negotiate with patients, and to offer them, I don't know, nicotine patches. Can it wait until tomorrow? Can it wait until we remove your chest tube? Try to be a good negotiator for your patients, and don't forget to offer patient passes when they're stable. Like if someone is just waiting for a repeat CT post-op. They're super stable, but you just want to check, I don't know, if your fixation was okay and your staff agrees and your senior agrees, offer the patient a weekend pass, because this will really help patients be more involved in their care. Get help from other professionals, so get physio, PT, social services involved early on, and you can prepare these consults for all those services also while you're in the OR, if you know for sure that the patient will need help with mobilizing post-op. And learn to be proactive when you are waiting for a CT scan, for instance, for a trauma patient. First of all, look at the images yourself. Always look at all of the images you request yourself. And if you see anything that raises questions, don't hesitate to call the radiology resident and discuss the findings with them. Don't wait for them to write the report. Sometimes you will see things that they will take, you know, a certain time to report, and if you just get confirmation early on that, yeah, okay, there's a pneumothorax that you were not you know, too sure about, then definitely, you know, this changes management. So a quick case: Mr. G is a 60-year-old who is booked for a small bowel resection after failing conservative management of SBO. During morning rounds, the patient has changed his mind and wants to eat and leave, and he is like pulling at his NG and threatening you to leave. How would you approach this patient? And for sure, it will be the R1 who gets the call from the nurse, you know, come and convince the patient. This is the typical junior call. So I will select a victim. Angela? Oh, Drew. What specialty are you in, Drew? Drew is not here. Maybe Hamid.
Yes, I am orthopedic resident.
Oh, hi.
Yeah, hi.
So how would you convince this guy?
So this patient's already failed the conservative management. That means most likely he spends days and days maybe suffering in the ward. Mm-hmm. So that might contribute to the fact that he is refusing the surgical intervention. So I will go to the patient. First of all, I will assess if the patient in distress or not. Mm-hmm. I will check his vital signs. After everything is fine, the patient is stable, he is only refusing the surgery, I will ask the patient why he is refusing the surgery. First of all, I want to start the negotiation between me and the patient. I want him to feel that he is involved in in the management, and we respect his opinion, and we are here to help him. And he is the cornerstone of all of these things around. And so I will just ask him to elaborate more. What's the problem with him? If he's mad of anything, if he's maybe in pain, mm-hmm. Maybe he's asking the nurse for something and they are refusing, or maybe no one is giving him attention for his pain or his discomfort. Just I want to elaborate what's the problem with him.
Exactly, and you're absolutely right. So many times what you will hear from patients, especially like patients who are waiting for OR, is that they don't want the surgery anymore because they've been NPO for like 2 days. And sometimes we book patients, they're category 3, we tell them, oh, we hope you will get your surgery tonight. But you know, but they don't. So it happens very frequently.
This happens in orthopedic.
Exactly. In ortho, you will get so many angry calls for that. We also get that in urology. Gen surge a bit less, because if they book a category 1, you know, it just goes. But for the specialties that have like category 2s and 3s, oh, these patients, they just get bumped. And
they have right. If I'm in their place, I will do the same. If no one is explaining to me and I feel that I'm neglected, and I will do the same maybe. So just if we explain to them that you are the priority. However, there is another, for example, vascular problem or another open wound or something more urgent came. They will, most of the time, they will understand.
Yeah, you are absolutely right. So thank you very much for your comments. I'm really reassured. I mean, you guys will do great. If that's how you approach someone like that, I'm really reassured, because you will have to deal with all of this anger. Like, the collective anger will always fall on the youngster. So you have to be ready to approach it, and the way to approach it is to really figure out why they're angry. And if it's, oh, I've been in PO for so long, okay, I understand, maybe we can let you eat for tonight and you can be fasting again at midnight. So try to think, of how long you've been keeping someone in PO. In this case, NPO is the therapy for SBO, so that's not so bad if they stay in PO. But try to be mindful of how long patients are waiting for OR, or how long they've had an NG and they've been connected to a wall and they have the pole with IV fluids and they can't walk or go to the bathroom because of that. So be mindful of all of these, and if you just take the time to discuss it with the patient, it will really reassure them. So thank you, Hamid. Now, also survival tips, you will need to diagnose a few things. So you will need to be able to interpret your images before the result is out. And this is especially true, well, this is really actually true for everyone, but gen surg, urology, ortho, trauma, vascular, everyone needs to be able to, look at the images and see the gross things. You need to be familiar with them. You need to be able to see a dissection. You need to be able to see hydronephrosis. You need to be able to see ectopic pregnancy if you're gynae. You need to be able to see the main findings of your specialty. When you're rotating on trauma, you need to systematically look for pneumothorax, hemothorax, effusions, rib fractures. Some of them you may see, some of them you are more difficult to see, but if you have a flail chest, so 3 consecutive rib fractures, you need to identify them yourself. Also, if you order a chest x-ray for someone who's desatting, like what happened to Simon, don't forget to look for pneumoperitoneum, because you ordered a chest x-ray, for a completely other reason, but you should not forget to always look for, free air under the diaphragm, or, signs of free fluid. Then look at the bowel loops on an abdo x-ray, and if you're ordering a CT scan and it has contrast, look for active blush in the trauma context. That would tell you that there is active bleed. You also need to be able to interpret the blood gas on your own. Now, I'm not talking, mixed acidosis, alkalosis level, but the gross, findings. And abdo X-ray, you should be an expert at seeing post-op ileus, SBO, LBO, air under the diaphragm, and also you need to become a poop specialist and see if there's huge fecal load like a fecaloma. And Drew is back, no problem. You will be getting the next question. Also, how to survive. Learn to anticipate. If you are, let's say, who was gen surg? Drew, what specialty are you in?
I'm orthopedics.
Oh my God, there's so many ortho residents this year.
Yeah, 7 of us.
Wow, okay. I just know Lucy and Salim who are, and am I missing anyone else my year?
There's Dina. There's 3.
There's
Yeah,
Dina too, yeah. So you guys are lucky to be 7, that's good. So if you have someone, when you do ICU, because you will be doing ICU as an ortho, you get consulted for someone with severe sepsis. They're hypotensive 70/50. How can you anticipate, what's going to happen? How would you approach, the consultants and the OR management of this patient?
Is that for me?
Yeah.
Initially, do we know where the source is? Like, do we have a source identified, or?
Yeah, you know that it looks like it's cholecystitis because there was an ultrasound done, and it's thick. There's gallstones, and yeah, it looks like it's cholecystitis.
Well, you want to make sure they're like acutely stabilized. So fluids, broad spectrum antibiotics.
Yeah.
Take blood cultures before if you can.
Yeah.
Obviously assess do like a physical exam, assess their mental status, their breathing, see if they're like at a risk of decompensating further. If they need, they'll need like a surgical consult, depending on what the situation with the gallbladder is like. They might need like an urgent percutaneous tube, Foley tube.
Yeah.
If they are stable enough for surgery, then you'd want to start keeping that in mind as far as like the anticoagulation. Make sure they get a COVID swab, stuff like that.
Yeah, nowadays, yeah. Right. So you said for sure we're gonna end up consulting gen surg on this, and yeah, maybe it's gonna go to OR, maybe it's gonna go to IR to get the percutaneous tube. So you could order already INR coags as you see them in emerge. Okay, like fine, the patient is not crashing now, they're stable, you gave IV fluids, you gave IV antibiotics, you're the ICU team, you decided that you don't need to intubate, everything is stable, and you check all the lab work that was done, and you see that there are no coag profile done. That may sound silly, but that coag profile, if you forget to order it, may make the whole difference between the patient getting the percutaneous tube in 1 hour versus getting it in 3-4 hours. So source control is important in sepsis, and someone who's has cholecystitis, cholangitis that's really bad is not likely to go to OR for that. Like gen surg doesn't usually take this to OR. So you'll need to check INR and coags, and here the interventional radiologists are pretty meticulous about getting coags before doing any type of procedure and documenting the coags. They usually accept an INR that is less than 1.5. So if you are talking to the tech and the tech says it's 1.5, you need to give FFP. FFP won't fix that INR because FFP has an INR of 1.6. So there's nothing you can do to, fix an INR of 1.5, and they can have high INRs just because they're in liver failure because of their sepsis. So get the coags, going, and check last thromboprophylaxis dose, last aspirin, last Eliquis. These are silly details, but they really, really matter when it comes to the delta T for, the patients to get whichever intervention you're asking from IR. So start being mindful of that. Yeah, that's otherwise, exactly as Drew said, so fluids, IV antibiotics, get gen surg on board, start thinking what are the options. If it's not going to OR, where is this patient going? Are they going to the ICU? Are they going to IR, etc., etc.? So thank you, Drew. And this will go to Simon. I will just describe this case. I'm really sorry, Orso. You guys, I'm picking on you without, knowing beforehand. So sorry. You're the ACS resident at the MGH, and you get signed out over the weekend, and you start Monday, and it's 6 a.m. and you know that there's a patient that has been admitted to the service for more than 3 months, and initially was admitted with chronic pancreatitis, and then it became chronic. And you checked, it was Sunday night, you had nothing to do, you started checking everyone's labs because you're young and insecure. So you ran through everyone's labs and you saw hemoglobin of 66, but you figure, he's a chronic patient. I'll see tomorrow what's up with this hemoglobin. And as you start doing your rounds, you overhear, the nurse calling overhead for the ACS resident, you're required in room 16, your patient is not doing well. And you get in the room and the patient is obese and he looks in distress and he's so fat that you can't even get vitals, like the blood pressure cuff doesn't fit his arm, that he has like an IMC of 50, and yeah, he just looks cyanotic, in distress. What would you do, Simon?
Do I have a saturation at least or nothing?
Nothing, not even like it's not reading.
Okay.
But he's blue.
He is blue. Does he have any past medical history of COPD or does he have any puffers?
You don't know, like you got handover and you don't know.
Oh, so they didn't give me a good handover.
No, no, because
okay.
Yeah.
Okay. First of all, I would start him on oxygen.
Yeah. Yep.
Then I would ask for the nurse to request a portable chest X-ray stat.
But you just have that one nurse, and if the nurse goes, then you're alone. Yeah, they're gone.
I want 2 good peripheral vascular accesses, at least 18 gauge.
Yeah.
I want it to be plugged on IV fluids, although I would not give them right away.
Okay. So you did your airway. You did like you saw that he's blue, so you put him on oxygen. But are you sure that your airway is good? Like before going.
I would check his airway, see if he's not obstructed.
He's breathing fast. You see that he's breathing at like 30, but he can talk to you. He's like, doctor, help me. But he's breathing fast and he's talking a bit.
Okay, and does he have pinched lips or how's he breathing?
He's just he's so fat that you can't see really.
Okay.
Yeah.
I would raise the head of his bed to at least 30 or 40 degrees if it's not already done.
Yeah.
I would ask the nurse to send labs as soon as possible for repeat hemoglobin, blood gas, Chem10.
Yeah. So this gets sent, but it's gonna take 20 minutes to come back at least. He's you placed him on what type of oxygen, like nasal prongs?
Well, to start, if possible, yes.
But he's blue and you don't have a saturation.
I don't have a saturation.
You still don't have, like, still doesn't read.
Yeah, so at that point, I would probably call code, try to get him intubated.
Okay, but he's still responsive, he said, I'm good.
Like his saturation is just because it doesn't.
Yeah, it doesn't read because he's so fat. Like this happened to me. This was a legit, so that's how big the IMC is. Like you can't even get the probe properly on the finger. But he's blue, so that's.
You have an optiflow close?
You need to call ICU.
Yeah, I would call ICU.
Okay, that's good. Okay, that's good. Good. But ICU will ask you, what are the vitals? What did you do? What are, all of this? And it's good to call them. And I would definitely tell them, I can't get the reading. He's blue, he's cyanotic, and I don't have any vitals. And he's breathing fast, and he looks in distress. Please come right away. That's how I would convince them to come. Because if you don't, say that you're in trouble, they're not going to hurry up and come to see you. So you need to, specifically say, I need you right now.
Okay.
Good. But nasal prongs, he's blue. I just wanted to say, you have nothing to lose if you put him like on Venturi mask, right? You have nothing to lose. So ask the nurse, put oxygen on mask, and you're probably going to be too stressed, to think of Venturi mask, what color of the adapter or whatever. No, you just tell the nurse, put him on the maximal oxygen that you can, and they're going to, help you figure this out. So, okay, let's say airway we're not fully sure, but at least we have someone who was talking a little bit and who's blue, but under O2, and ICU is coming. And you mentioned, you know, calling a code blue.
Well, if he had no, like, if I had zero saturation, it could mean that he has no circulation. But if you're telling me that it's just because I can't get readings, it's not.
Well, you don't know. You don't know.
Yeah,
But he's responsive. So, because he said, help me, doctor. But then 2 minutes pass by and he, you know, you see his eyes rolling back.
Then I would assess his Glasgow score, and if he's unresponsive or he's below 8, then I would call code blue for the patient to be intubated.
Yeah, now you're rubbing, you know, his chest, and he's not saying, help me, doctor, anymore. He's no longer there.
Yeah, I would call code blue.
Okay. I sort of tricked you into not calling the code blue earlier, but it would be 100% legitimate to call the code blue when you have someone who you're not able to, you know, get good vitals. You try to get good vitals and he's cyanotic. So that's, the two together are already a good reason to, you know, call a code blue. And yes, the patient is still responsive, but the point is to call a code blue early on before the patient becomes unresponsive. So it would be, it depends. If you can get, you know, a senior to help you and you can manage the patient quickly, you can avoid calling a code blue. But if you're alone, like you were over the weekend, that's a situation where it's 100% legitimate to, you know, just call a code blue. Tell the nurse, call the code blue.
Yeah, can I ask a question?
Go ahead.
Yeah, at what level can I ask? I mean, what is the time that I can ask? It's the time now for code blue. I mean, so before patient is already crushed on, I mean, when can I call them? At what level?
So I would say anyone desaturating that you're putting, you know, that you put a Venturi mask and they're not like outside of this case, you have someone who's desaturating to 80%, you put them, you know, on Venturi mask as a sort of temporary measure and they're still like desaturating and it's 80%, that's a code blue. So anyone who's desaturating and not responding to O2 should get, you know, a code blue. Anyone who has tachyarrhythmia and is unresponsive, code blue right away. Tachyarrhythmia, of course, no circulation. This guy, you're not sure if you have vital signs or not. You're not sure if it's because he's too fat, but he's cyanotic. Like when you're cyanotic, you're below 80% for sure in terms of saturation. So yeah, that's this guy. You can totally call a code blue. You see he's cyanotic and you can't get vitals, call the code blue. And you know, what's the worst case scenario? The ICU team comes and he's suddenly pink and suddenly you have vitals and they're all normal and everyone goes, you know, back to their service and they're happy that they didn't have to code someone. So the consequence of calling a code for someone who is, you know, presumptively unstable are less than the ones of calling it too late.
So we have here code blue and ICU, right?
Yes. So
they are two different teams.
So here you call the code blue team, and now it depends. I'm so lost with the COVID situation. It depends on each hospital, like who runs the code blues. When I was at the MGH, I was ICU a month ago, and I was covering the code blues for all the hospital. So we were showing up, and internal medicine was also covering the code blues. So if you call the code blue, you know that someone is going to come and help you. And I think now with COVID, that includes anesthesia to help you intubate, because with COVID, it should be the most experienced intubator that should do it. So I think since COVID, anesthesia comes automatically to the code blues. And now depending on the hospital, the team, the code blue team may be the ICU team itself. It may be the same team or not, but so many things have changed. I'm not too sure. So if you call the code blue first, and then you can call the ICU. If for this patient, things would, you know, you put him on the Venturi mask and then you get vitals and he's saturating okay, I would just call the ICU team, because you can't keep someone with a Venturi mask on the floor. That should go to the ICU. So say you start your A like Simone did, and you have saturation of 90%, that works on the saturometer after that, just call the ICU. You don't have to call a code blue.
If someone's not in the ICU and you want to intubate them, are your only options to like call a code blue or like consult ICU?
Yeah, exactly. Unless you want to intubate yourself, but that is not recommended. That's actually not something you can do, because you won't have the crash card. So the crash card magically appears only once you say, I'm calling the code blue. If you shout, I'm calling the code blue, and someone presses on the code blue button, then someone magically, pushes a cart that has all the equipment. So just by saying I'm calling the code blue, all the equipment will appear. And sometimes we call the code blue just so that we can make equipment magically appear. So for instance, you have someone in AFib running at 200 who is super stable otherwise. It has happened at the MGH that the code blue was called just so we could give IV amiodarone, because the medication is not available otherwise IV on the floor, and you need to give it. So you call the code blue because you need IV amiodarone. So in these kind of situations where you call what is a soft code blue, you sort of plan it ahead and you consult the nurse and you ask, the nurse in charge, can I get IV amiodarone on the floor? And they say, no, you have to call a code blue for that. And you say, there's really no other way I can get the medication? And they say, yeah, there's no other way. So then you say, okay, well then I'm calling the code blue. And then everyone comes running, and you sort of have to be nice to your colleagues, who are running to come and help you, and be like, no, it's okay. It's just, for IV amiodarone. So sometimes we call a code blue just to get equipment. And I mean, it's okay, like 200 AFib should not be on the floor either. So then ICU team comes and they assess, and they may take to their ICU, but that's not a code blue, situation where you have 5 to 10 minutes to fix the patient. You have like 4 hours, of monitoring and seeing if you can fix the AFib on the floor. So no, it's not recommended that you intubate yourself. And now with COVID, it should be intubated by anesthesia only. Patients should get intubation by anesthesia. Any other questions from anyone regarding to how to call a code blue, when to call a code blue, what happens when you call a code blue? No? Okay. So to move on with this case, it was like my second or third month. So I also was hesitating. Should I call the code blue? Should I not call the code blue on this? But when I saw that I had only one nurse, and that it was me, and that I was asking for transfusions, because then I get to my C and I'm not sure I feel pulses. So I'm like, I'm going to transfuse, because I remembered that he had a hemoglobin of 66. When I started shouting, can I get the transfusion? And no one was like answering, and people were just passing by. I said, oh, what if I call a code blue? People are going to hear me. So then I called the code blue, and then I got a nurse to call, the blood bank, and suddenly I got a massive transfusion protocol, and blood products were just coming. And like maybe 2 minutes after I said I'm calling the code blue, there were about 10 people in the room. I had an anesthesiologist intubating the patient, and I had 2, fellows from the ICU who were there to support me. So my mistake was that I waited too long to call the code blue. I could have gotten help earlier on, but I was just so insecure, about, oh my God, I'm gonna call the code blue. It's my first day. I must be exaggerating, No, it was actually what happened is that when we got the VBG results, the patient had a hemoglobin of 23. And to point out the importance of good handover, again, the hemoglobin was 66 when I had checked it, but it had been 77 the day before. It's not that much of a drop, 10 points, in a day, but no one had compared, with 2 weeks ago when it was like 130, and the patient had been like silently bleeding from an ulcer. And his hemoglobin was 24 when we checked it on the VBG. So, so again, handover is so important. Things like that, the patient had been passed on from team to team, and no one had noticed how big the drop was compared to 2 weeks before. So it resulted in like a silent ulcer all this time. That's it. Okay, then let's move on to technicalities. How you will need to be the person who can fix any tube-related problem on the ward. So does anyone know how to remove a JP? Is there
Take
anyone?
suction off and pull.
Yeah, exactly. So don't forget to take the suction off. And what if you're pulling and it's not coming out, like it's really stuck? What are you gonna think of?
Double check, make sure it's not sutured somewhere.
Okay, it's not.
Then
You're pulling and the
pull
patient,
harder.
yeah, okay, and you're pulling really hard and the patient is screaming like they're dying. What do you do?
Pull as hard as you can for a second, and if that doesn't work, then consult the team that put it in.
You're the team that put it in.
If it was not coming out at all, then I would ask a senior, or maybe just get some type of imaging. But
yeah, and
usually
what
they
are
come
you
out.
gonna look for if you look for imaging?
You could look for it to be caught on something, or like adhesions or something like that. Just some type of.
Where's the worst
If it's
place
like
it
tied
could
in a
be
knot
caught?
or kink.
Yeah.
The worst place it could be what?
The worst place it could be caught for you.
Where is the JP drain? Is it intra-abdominal?
In the abdomen. Yeah, in the abdomen. It's not very typical of ortho to leave intra-abdominal GPs, but say you're rotating on gen surge.
The worst thing would probably be an artery or some loop of bowel. Probably an artery if it was a big one, but that would be harder to get caught on than like a loop of bowel.
So bowel, okay, bowel, I'll take bowel. Artery, it's difficult that it gets caught on arteries. It just doesn't adhere to arteries, or you would need to transect it and the patient would be bleeding out, so you would know. But the worst place it can be caught is you have stitched it to the fascia. When you were closing the fascia, you stitch it to the fascia. So then you can try pulling as hard as you can with your like ortho superpowers. But if you did a good fascia closure, then it's not gonna come out. So you need to realize that if you cannot pull out the JP and you've tried, and Anfal is suggesting, putting a clamp on it. I don't know if she's suggesting it to like get more retraction. That's a good idea. So if you've tried to pull it out and the patient is screaming in pain, consider, call someone, a more senior person to have them try. If they also fail, then imaging, Drew, as you said, is a good plan so that you can see if it's caught in the fascia. And if it's caught in the fascia, the patient needs to go back to OR and have the fascia sutures opened and closed again. So yeah, removing a JP, you can try pulling as hard as you want, but just keep in mind it could be stuck to the fascia and that's why it's not coming off. Then second thing, you'll need to be able to troubleshoot inserting NGTs. Anfal, do you know how to insert an NG? Have you done it on the floor already?
Yeah.
Yeah.
So
go ahead.
Okay, so initially we need to measure the length of the NGT. I mean, so it's from the tip of the nose.
Yep.
Then we go behind the ear to the xiphisternum.
Yeah.
We put a lubricant.
Yeah.
We can ask the patient to like lie 45 degrees on the bed. And
90. You want them sitting down.
Yeah, sitting. Yeah. Sitting position, and then we can ask the patient to like swallow, trying as if he's trying to swallow water or something like that, and then we proceed putting the NG, and then to that to the length that we have measured initially. and then we can try to confirm the position. It's either to aspirate or to inject air and auscultate to confirm that it's in the stomach actually.
Okay.
And yeah,
And
then we have to fix it.
yeah, exactly.
Yeah.
So most of the NGs you will be inserting as a junior because there are very few nurses who can insert them. So unfortunately, you will become an expert very early on. You know, the easiest way is that you can aspirate and see if you have any gastric content coming back. But, you know, I haven't really, I don't know, I'm really bad at auscultating, so I haven't been pushing air listening, and I lost my stethoscope very early on. So I've just aspirating and checking the abdo X-ray afterwards is the most sensitive, you know, way of confirming position. And if you insert it in the trachea, you'll see the patient desat, so you'll know that you inserted it in the wrong place early on. Same thing for dob-offs. It's the same technique. It's just that you need, do you know the difference between a dob-off and an NG? Actually? Yeah, that's okay. So dob-offs are for feedings that are post-pyloric. So sometimes we insert it on patients who will need you know, chronic enteral feeds, and they're more comfortable than NGTs. And really the purpose is to feed the patient, to give them enteral feeds. So they're smaller than the NGTs, which also means that they're harder to insert. So as to make it easier for our insertion, they come with the guide wire. And so you push it in, it has a guide wire, and then it's the same insertion technique, just like the NGT. It's just that you keep the guide wire and you tape the tube to the patient, and then you immediately get an abdo X-ray. If you can see that a position is adequate, then you go in the patient's room and you remove the guide wire. So that's the dob-off and the NGs. The difference is that you have a guide wire to keep on the dob-off until you have confirmed position. Another thing you will need to become an expert at is to, you know, confirm position of central lines and these GI tubes. Nurses will call you, can I use the NG? No. Can I use it for feeds? Can I use the dob-off for feeds? So you will need to be able to interpret those images. You also need to become an expert at blocked pegs. I failed to become an expert at blocked pegs. All I know is that there is somewhere in the hospital, there's a protocol. So you just ask the nurses, would you know by any chance where I can find the protocol for blocked pegs? And it's supposed to be an enzyme mixture that will, that you just irrigate the tube with so that it can remove and dissolve any clots formed in the peg tube. And you also need to be an expert at inserting Foley's. And for this, I recommend that you all become friends with Anfal, who's in urology, so that you learn. Learn to fix problems. Okay, so here we can see, this is a dob-off, and we can see, if everyone can see my mouse, you can see that it is coiling in the stomach, and that it seems to go past the pyloric junction. So that is a dob-off in good position. Then here, anyone can see what we see. Let's pick someone. Maybe Angela is back. There's an Angela. If not, a volunteer. Yasser in plastics. Oh, choose another victim. Anne. What do we see? Oops, on this one.
I'm not seeing the picture really well, but I see that there's a line going in the trachea or the esophagus. And then I think below the diaphragm, I don't know if it's the same line, but below the diaphragm, I see it, and I think it might be too far past the stomach.
Okay, so what would that be as a line?
I'm assuming an NG or a double.
Yeah, exactly. So this is an NG, and you know it's not a double because it's not coiling as much, and because the line that you can see is a bit bigger, but this you're just gonna get used to as you see more and more. And so how, you know, the NG is in good position, two conditions. It needs to be past the midline. So here is the midline, and you see that it's going past the midline. So that's good. And the other option, it just needs to be under the diaphragm. So it may be a little bit, you know, past, but it's in good position overall. You have your two criteria. It's past the midline and it's under the diaphragm. So you're good to go. You can say, go ahead and use this NG. Good, thank you. Let's take for the next one. Here we have a central line. And do you know how to assess for position of central line? It's okay. So basically, a central line can be, you know, inserted in the internal jugular, can be subclavian. It doesn't really matter where it's coming from. The important thing is where it's going. So here we can see, here we see the left atrium. And the important thing is that it does not go in the left atrium, because if it goes in the left atrium, it can cause arrhythmias, and you can have a patient go in AFib because the line is just irritating the atrium. So it should be in the superior vena cava and ideally 2 centimeters above the cavo-atrial junction, but we can tolerate it, you know, we can tolerate if it's at the cavo-atrial junction. It just should not be within the atrium. And if it's within the atrium, then you can go, you know, in the patient's room and sort of clean the area with Chlorhex, and then just pull it, you know, by how much you estimate that it's going too far in. But you can always pull out tubes to adjust their level, but you can't pull them back in because then you're inserting bacteria. So it only goes in one direction. And here, Abdullah, what do we see on this image? Or Aslan?
Oh, okay.
Who is this? Abdullah? Aslan? Abdullah, hi.
Yeah, hi. I see some lines going. They're on the chest.
Mm-hmm.
They're going towards the heart,
Mm-hmm.
or that looks like a chest tube. That's in the lung.
Yes. So that's a chest tube. And is it in good position?
No, because I don't see any lung markings.
Yeah, so the lung looks collapsed.
Looks collapsed.
It's still collapsed, so it hasn't
See
suctioned.
one of the openings of the chest tube, maybe outside the chest.
Yeah. So do you see which one is out?
Yeah, that one.
Yeah, exactly.
Yeah.
So can you just pull it in? You know, what do you do now?
You can push it in slightly, I guess.
But you're not afraid you're gonna push bacteria in?
I mean, am I sterile, or did I just put the chest tube in, or has this been placed?
Yeah, you put it in like 6 hours ago. And yeah, it took you a long time to get the chest x-ray because they're slow to get.
You can just push it in if you just like clean off the line first, or clean off the tube first. Just like wipe it off with something antibiotic. You can just push it back in, right?
Area.
No, we can't do that, guys. Don't do that.
For chest, like for central lines, I know it's, but like for chest tubes, I've pushed many chest tubes in.
Well, we shouldn't be. The practice should be that we put another one. So it really sucks for the patient, but we should be putting another one if it's not far enough in. So I have had, on my side, I've had to, put in many times second chest tube on the same lung just because the first one wasn't far enough. But if you are in a crash type situation, like I think Abdullah was initially thinking, yes, you can totally push it in. If you're like in trauma bay and the patient is still crashing and you have that chest tube, you're pushing that one in. And then if it doesn't work, you can reinsert another. But if the patient has gone, to the ICU, it's been 6 hours, now they're in another room, you can't push it in. You have to put in another one.
Yeah,
So,
but that wouldn't touch or injure the lung parenchyma or the right ventricle or left ventricle, we'll say there.
No.
That's not too close.
No. Sometimes you will see that they will even, like the chest tube, you will push it like a good 30-40 centimeters in, and you can even see them. It's okay to even see them, at the apex of the lung. Now, on the image will not really tell you if you went in unless you see the tip here. Like unless you see the tip really far in, you won't be able to know that you injured. What's gonna tell you that you injured the patient is having someone crash, acutely after you put the chest tube. That's how you're gonna know that you just perforated something that you shouldn't have. And by the way, injuring the lung parenchyma, you don't really care. It's more like the heart or the liver, because the lung is like already scrap. So the things that you should, be afraid, maybe the heart, but it really takes special effort to injure the heart when you put the chest tube, because once you're in with your chest tube, the direction that you're pushing should be superior. And if you just direct it superiorly and you're on the lateral edge as much as you can with your finger, you're gonna go in the right direction. So it's very, very rare. The difficult types, the difficult tubes to put in that are at high risk of injuring, vital structures are the ones you put in obese patients, because then it's very difficult for you to know which rib you're at. So those are the dangerous ones.
It's really the risk of a second chest tube is less than the risk of like a little bit of bacteria from pushing it in.
Yeah.
Do you go through the same hole that you made? I assume you don't do it.
No, exactly. A second hole.
Joanna, can you please just show us the tip? Where's the tip right now that you said it's a bit backwards?
Oh, so this is okay in terms of tip position. The tip is here, and what's not in enough is the fact that you see an interruption in the line, in the contrast opaque line, right? So you see the first one you see is here. So this is telling you that the first hole is in, and this is marking the last hole of the chest tube, and it's not in.
Oh, okay, thank you.
So to be honest, here we know that we have one hole. The first holes are in. So that may contribute to draining the pneumothorax, but obviously we still see that the lung is collapsed anyways. So to answer you, Drew, the guy's lung is not going well, right? If we had a completely re-expanded lung, by the way, we would not go through the trouble of putting in a second chest tube. Let's recall why we want to put another one. The lung has not re-expanded post-insertion of a chest tube that is not in proper position. So you have a mechanical failure right now. This chest tube is not working well, so you need to put in another one. And if you are in a crash type of situation, yes, it's okay to push it in. if you have time. If the patient is just like sitting at 88 and just chilling, then you take your time. The risk, you know, you're gonna do a good procedure. If you have time, they're not crashing, you have time to disinfect, you know, to do a proper local, you know, asepsia. You have time to prepare lidocaine. You have time to, you know, get your good landmarks. It's a good opportunity, by the way, to get your EPA done if you have to put in one of those chest tubes. You know, in the ICU, you notice the position is not in, and you all will have to do EPAs. That's a good EPA for R1s because they're not crashing. They just need, you know, a new chest tube because the first one isn't working. I hope this clarifies, you know, the need to put in another one. First of all, the first one is failing, the lung is not re-expanded, and there's the risk of inducing sepsis from the chest tube. And also just to complement, you know, how bad these tubes are at inserting bacteria. I have seen a patient in the ICU who had one chest tube, one single one, you know, who was manipulated multiple times. And he ended up having bacterial endocarditis and shooting septic emboli in his brain and become paraplegic because of septic emboli pretty much everywhere. So these chest tubes are not, as Drew was mentioning, he was saying it, like they're super high risk. So there's a risk with inserting them, but there's also a risk with keeping them in, and if they're not in proper position and we keep touching them and we don't put bacteria around them, there's also a risk of sepsis induced by the line. Then I will quickly talk about my pleasure, my passion, Foley's. When does a patient really need a catheter? When you need to monitor urine output, when you have someone in urine retention. Sometimes, gen-surg specifically, you may have a perineal wound and you need to help with the healing of the patient and you don't want any urine going there. So you can, you know, allow for healing by drying the region up. If you have spinal cord injury patients, what can a spinal cord patient be at risk of, say, 3 days after their spinal cord injury? Anyone from ortho or gen surg have an idea? Or maybe neurosurgery as well?
Retention, hydronephrosis.
Why would they have retention, the spinal cord patients?
Post-spinal anesthesia?
Yes, okay. But that's not what I'm looking for. It's, I think it's in the ATLS, so you may have, you may see it this afternoon with maybe Julien. So it's just patients that have, you know, a high level injury, like above T6. They develop what is called autonomic dysreflexia. And it can really present with hypertensive crisis, and it's really triggered, you know, by having the injury at T6 by a stimuli. It's triggered by an injury above T6, and it's because they have some sort of stimuli below that level, and it just causes. I don't understand very well the mechanisms, but basically the stimuli is not communicating well with the injury. So stimuli can be having full bladder, stimuli can be fecal impaction, pressure wounds. So you need to, you know, if you have someone who's hypertensive and who's a spinal cord injury patient, you need to think of autonomic dysreflexia and insert a Foley tube or do a disimpaction, and you will fix their hypertensive crisis post spinal cord injury. Yeah, so just something to keep in mind, autonomic dysreflexia. I won't go into these. And when we insert Foley catheters, just keep in mind that the longer we keep them, the more the patients are at risk of urinary tract infections and bladder spasms and discomfort, and also, prolonging hospital stay. And some patients that end up keeping the Foley catheter for months may end up having their urethra completely eroded by the catheter. Two types of catheters, 2 ways and 3 ways. 2 ways are the standard catheters. You put it in, you have a port. You have a port that's actually, okay, that's in the 3-way. You have a port here to inflate the balloon, and you have a port through which the urine is coming out. 3-way catheters are used if you have someone with hematuria, with clots, that needs an extra port for irrigating the bladder with water so that you can remove the clots. And just a tip for choosing the right catheter for a patient: if you have a male and you know that they are known for BPH, then you have a huge prostate. That's what it means. And so it means that you need maybe a bigger catheter so that you're able to bypass the obstruction. So anyone from plastics has an idea of a size of Foley you would be inserting in a standard male versus a male with BPH? It was Yasser or Joshua. I don't know if Joshua is in plastics.
I'm not having cardiac surgery and I don't know the answer.
Oh, okay, no problem. So a standard size of Foley is 18 French. So the nurses will sometimes, ask you before a case, oh, what size do you want? 18 French is a good universal size. And if you have a male and you know that they have BPH, you can counsel the nurses to put a 22 French. And no matter which specialty you are, you may get that 2 a.m. phone call that your patient is in retention post-op. And so you can advise the nurses, please do a PVR or a bladder scan, and please insert a Foley catheter. And you can even be specific and tell them a size 22 French if they have BPH. And if it fails, then you can try to insert the catheter. And then if that also fails, we will be gladly coming to give you a hand. Next, okay, so I spoke a little bit about the size. I will quickly go over some common things that we see on the floor. Atelectasis. So it should be an exclusion an exclusion diagnosis if you have someone desaturating or febrile. Some people even argue that atelectasis may not cause post-op fever. So things you can do if you see a patient in clinic and you know that they're smoking, patients we often see in urology, cardiac, vascular, try to encourage smoking cessation, offer the patient nicotine post-op, pain control, lung expansion techniques. It may sound silly, but when you're around, try to remind all your patients to do their incentive spiral. It may save you like a day or two of admission. So that's good for everyone, good for the patient and good for the team. Tachycardia. Tachycardia, I said it at the beginning of my talk. The vital signs tell us a lot about how a patient is doing. So it's definitely worth working up tachycardia. My advice is to get EKG and tropes on everyone over 50 who has tachycardia, just to see if there's sinus. If they're in sinus rhythm, most of the time, it means that there's an organic underlying condition. It could be sepsis, it could be PE. But you know that if you're in sinus, the patient is responding to something. So you can work it up. And then CBC, Chem7, BBG, blood cultures, urine cultures, bile cultures, chest tube cultures, all of the tubes that you have, think of culturing them, especially if it's associated with fever. And yeah, just think of your differential. If you have tachycardia, it's also worth, you know, trying a little bolus post-op, maybe not indicated in post-op cardiac surgery. Sometimes these patients are really like fragile when it comes to fluid overload, but for specialties that don't really have to fear lung overloading the lungs, then you can definitely give a little bolus. You can start with 500 cc's, 1 liter, whatever you feel comfortable with. And if you notice that the patient is responding to the bolus, it means that they're either dry or septic. So they definitely needed the fluid. Delirium on the floor. Same as tachycardia, it should also be worked up unless it's the patient's baseline. But usually you're gonna get a call. If you're doing home call, you're gonna get a call. Oh, the patient is seeing cats on the wall. What do I do? If the only thing, you know, that they see is cats and they're calm and they're not agitated, you can observe and just do the workup. But if you have to deal with agitation, if it's mild agitation, you can use Seroquel 25 milligrams PO. I say mild agitation, so it means that you have time for the Seroquel to have effect, exercise its effect. So calculate one hour. If you don't have time and the patient is not mildly agitated and is quite agitated, then it's time for Haldol. And you can start with 0.5, 1 milligram, whatever you're feeling comfortable with, IV or IM. And again, I've had situations where I was, you know, hesitating to give the Haldol. I felt, you know, I don't know, I felt like it was too early to give it, and then it ended up becoming a cold white. So I learned that it's always better to give it when they're mildly agitated, and when the patient is delirious, there's no really room for negotiating with the patient. So just give them Seroquel, give them Haldol, work it up, make sure it's not sepsis, it's not because you forgot to re-prescribe some home meds like once I found a delirium that was caused by Synthroid that was not pre-prescribed, and the patient hadn't been getting it for like 3 or 4 days. So check the meds as well. AKI on the floor. So first thing, you know, you're rounding on a patient and you notice that for 3 days the creat keeps rising. What do? Well, you can just make sure it's not obstructive. So do a bladder scan, check if the patient is in retention. Check the urine output. If you notice that they have less than 0.5 cc's per kg per hour, then you can consider a bolus. So always, if you have AKI, do a trial of fluids. Once you've ruled out obstructive AKI, do a trial of fluids and then see how the creat responds to that. And consider consulting early on, you know, internal medicine, nephrology, if the AKI becomes unresponsive to fluids. Febrile UTI, again, just cystitis is often a complication of our interventions, whether it's gynecology, urology, ortho. UTI is the most common post-op complication worldwide. So simple cystitis, though, should not cause fever, so it can cause dysuria mainly. That's the symptom that should really clue you. Dysuria frequency. But if you have these symptoms and fever, then you should consider getting some sort of imaging on your patient, because then it's suggestive of pyelonephritis, and pyelonephritis can be obstructive or not. So just keep in mind that we don't usually consider cystitis to be febrile. So it needs imaging if there is fever. Desaturation, I think we covered it pretty much. Just one extra thing I would add, someone who's desatting, don't forget to consider CT angio, PE. And if you're in the ICU setting, you will learn that you also always have like an ultrasound machine. So you can take the ultrasound machine and just apply it, you know, on the lungs. And if you see bilateral lung sliding, that's reassuring when it comes to pneumothorax. So if you have a patient, then you can just overload. Julien, am I overriding your presentation? Just let me know.
No, all good. I think we have until 3:30.
Okay, okay. So yeah, so if you have desaturation and you're in the ICU, you can get an ultrasound and see if you have bilateral lung sliding. That's a good idea. But you can also do like the standard workup always first. Consider CT, angio, PE. And also to keep in mind, if you ever remove chest tubes and then the patient desaturates after you have removed chest tubes, then consider that you may have caused re-entry of air and that the patient has now, you know, iatrogenic induced pneumothorax, and you may need to reinsert another. So that's another situation. So when you remove a chest tube, you need to apply a proper dressing and to get a post-removal x-ray to really see if the pneumothorax reappeared. Wound problems, if you have a patient who has laparotomy incision, you should always examine it. It's easy to forego looking at the wound, but it takes 2 seconds to look at it, and you can avoid, you know, dehiscence becoming too advanced by just always inspecting the wounds. So look at the wounds. Maybe more difficult if the patient is in a cast or something to assess a wound, but try to assess the wound, and depending on the staff that you're working with, you will see that for abdominal discharge from a wound, some staff will say that you can probe the fascia with the Q-tip. Some staff firmly believe that you should not be doing this because then you're inserting bacteria. If there is like a facial dehiscence, you may be inserting bacteria from your Q-tip all the way down to the peritoneum and then cause yourself bacterial peritonitis. So before you probe the fascia, ask the senior or the service that you're working on if that's something that they do. And always abscesses need to be drained, and then antibiotics come second. A few tips for the managing perineal abscesses. You will do this a lot in gen surg, ACS. Take some local sedation, and if you have imaging, then you can look and try to localize where the abscess is. If you don't have any imaging, consider, you know, if the patient needs one, if they look like they have Crohn's or something. You don't want to drain, you know, an abscess that is actually like a huge fistula that would have required OR drainage. So look at the imaging before. And a few tips for calculating how much local anesthesia, I said local sedation, it should be anesthesia. How much local anesthesia you can give. You can use 1 or 2% lidocaine with epi if it's not you know, on the appendages, 5 to 7 milligrams per kilo. And I put here how I calculate, you know, how the max dose of lidocaine with epi. And usually I just remember that for a 70 kilogram adult, all this calculation gives 35 cc's. And try to think of all the equipment that you will need. You'll need a blade, scissors, Kelly clamp, gauzes, a lot of NS for irrigation, mesh to put in because you will want this to heal by secondary intention. And once you open, you can either do sort of a triangle with your scalpel to open, or a cruciate opening as well. And once you open and you have the pus coming out, you can use your Kelly clamp or your hemostat to really go and catch all those loculations and drain them. You'll see, it feels very good to get all those loculations. Then you have, here I'm just describing a case that presents with pancreatitis, and it's a pretty straightforward presentation. And what I wanted to mention is try to think of the investigations that your patient will need. You know, if you have someone coming with pancreatitis, then think of the causes: biliary, alcoholic, calcium, triglycerides, all of these. You know, you can order from the first moment when you see the patient, and the results will help you direct management. I won't go any further with that. Skip this. Quickly, how to pronounce someone dead. You will need sometimes, unfortunately, to do this on the floor. So pronouncing someone dead, well, it's a pretty difficult situation, especially when it's your first time and the family's in the room. So you have to, take a moment and go introduce yourself and offer your condolences. And you can ask the family if they would accept, to leave the room while you examine the patient. And what you're going to do is examine the general appearance of the patient to see that there's no reaction to verbal or tactile stimulation. You can look at the pupils. And I always examine for breathing and pause for 1 minute for each. And then it's important to chart your findings. You note the date and the time that you're pronouncing the patient dead. You say that the family was notified or they weren't. And especially important for everyone rotating on trauma, all trauma deaths need to be mentioned to the coroner. So the number is 188 coroner, I think. And all the trauma deaths, like even though the patient fell 3 months ago and they died because of, medication-induced arrhythmia, they are still considered a trauma death and the coroner needs to be called. And so when you pronounce the patient dead and then you call the coroner, they will say, they will sort of tell you if they need to look into the case or not. And they will tell you if you can remove the lines, but usually if it's a coroner's case, then you can't touch the patient. You can't remove like fully, you can remove the IV lines. They have to stay that way until the coroner tells you what to do with the corpse. So also other situations where you would have to call the coroner when the patient was admitted in the hospital less than 24 hours, sometimes. If the patient is incarcerated, coming like from prison or any like correctional institutions, if the death had any unusual circumstances, if the death was associated with trauma. And also another thing that you will need to do is to talk to the police sometimes. So you may get a page from the police who will want to know how a patient who was a victim of an MVC was doing, or a patient who was a gunshot wound victim is doing. So I suggest you take a screenshot of this checklist, and it sort of tells you what you can say to the police and what you can't. But my survival tip so far has been, I will get, I'm not sure I can disclose this information to you. I will look into that and call you later and just let them call, again, if they really want the information. Sometimes they will ask you like, how is the patient doing? What's their prognosis? They don't need to know that. We should not be disclosing that. So we can just disclose that the patient is with us if the patient is under criminal investigation, or that the patient is deceased if the patient was like a victim of a gunshot wound. But otherwise, we shouldn't really be disclosing information to the police unless they have a warrant. But they always call, they know for some reason the spectral numbers of like the trauma or the ICU service, and they call and they want to get information. The information we give them, they can use. So our duty is to the patient, not to the police. And so I just suggest that everyone knows that we should only talk to the police when they show up with a warrant. And quickly, a few tips on how to admit and discharge patients. This is my typical admission routine. Once I do a consult, I check the allergies, I check the DSQ, I print the home meds. And then when it comes to represcribing stuff, I basically always hold antihypertensive, metformin, antihypoglycemiants. I put the patient on an insulin protocol if they're diabetics. And then I think, do I need to hold or not anticoagulation for any type of procedure? I represcribe all the medications that could be at risk for withdrawal, like antidepressants or benzos. These you don't really want to stop. And I consider nicotine for the smokers. Then I think, why is my patient getting admission? Is it because they have rib fractures? So it means that I should be using the rib fracture protocol. If they're admitted because of alcohol withdrawal, then we have a protocol for that as well in most hospitals. If they're admitted because of sepsis, okay, then I should be putting antibiotics and fluids. And then comes my admission package. So if you want to take a screenshot, if you're not familiar with these meds, I always put Tylenol, Dilaudid, Zofran. I don't give Gravel to everyone, especially the elderly. And Zofran is a less of a QTC prolonging medication than Gravel. Laxidase, Senecot, and for some people, Zopiclone, which does not induce dependence for insomnia. So I avoid these 10 p.m. calls that the patient can't sleep. But of course, you adapt this to the patient's allergies and weight and all of that. Then you have the medical orders that most of you are familiar with. So activity, diet, and the vitals. And then don't forget to think of like the fluids. Do you want the urine output measured? Do you want to replace NG losses? Do you want the chest tube clamped after more than 1.5 liters are drained, or more than 250 cc's drained per hour for 4 hours? Also, you can put parameters to get a phone call: fever, tachy, I don't know, hypotension, increased abdominal pressure, anything, and dressing orders. And don't forget that the labs go in Oasis, and then so you also need to put in Oasis all the labs that you will want on a daily basis, and think of whatever you're monitoring, tropes, VBGs, and put it in the system so that you don't have to run after the labs. Okay, I will not. And just quickly, a few tips for getting someone to the OR. If you're seeing a consult in Emerge, it's like a compartment syndrome and it needs to go to the OR quickly. Just take a sticker with you, discuss the case with your staff, get consent, from the patient. So you need to sign a consent form from the patient. You also need, for everyone, a blood transfusion consent, and call the OR to announce your case. If it's a category 1, just call them, get them ready. If it's a category 2 or 3, you can drop a yellow slip from the OR desk. And sometimes you will also need to call the admitting office to see if there will be beds post-op for the patient, but really that should not be something limiting you bringing someone to OR. And think of antibiotics and thromboprophylaxis as well. Okay, I will stop here and see if you have any questions. Did you find it helpful?
Very helpful. Thank you so much, Ioana.
Thank you, Shafiq. And don't forget to eat. Sounds silly, but don't forget, like some rotations, you just know that you won't have time to go, to the cafeteria while it's open. So sometimes, just get, I don't know, get a few protein bars with you. Don't forget to sleep, although it will be, sometimes very hard. And always help your colleagues, like the people who are in this group in surgical foundations will become your allies and your friends and will be there to support you. Sometimes I'm calling, my colleagues in plastics or in gen surgeon, I know who they are, and it just feels so good when, I need help, I need a consultant, and that consultant is actually one of my co-residents. So I hope you all will help each other. And I'm leaving the floor for Julien for the ATLS review. I don't know how to give hosting powers. He seems to have them already.
All right, guys. You guys want, Julien speaking, you guys want to get like a 5 minutes break for water, coffee, or whatever you want. And maybe we can meet in 3 to 5 minutes and we'll start. By the meantime, we'll set up the PowerPoint and everything. Sound with you? Let's see. Let's see if I can hijack the screen here. Okay. Can you guys see my screen right now?
Yes, Julian.
Yeah.
Super. When's your exam, guys? Because I heard you guys have an exam for ATLS.
Next week, Tuesday, Wednesday.
Tuesday, Wednesday. And what's the format? Is it only question, or you'll have like some sort of pseudo simulation?
Good question. I don't know what's in person Tuesday, Wednesday.
Okay. Okay. Let me see who's here. Abdul Shamari, same as ortho. So we'll go through the names. I'd like to know who's doing what specialty, so I can pick on you accordingly.
Yeah.
Are you around, Abdullah Shamari?
Yeah,
Like my buddy in my years, Abdullah Shamari as well. What are you doing?
Hi, I'm an R1 in general surgery.
Superb. Who's 2000? Whatever. Okay, Abdul Majid. Online? Muted? Gone? Alexandre Machado Gedeon. What are you doing?
I'm in OBGYN.
Superb. Anfal?
Urology.
I didn't hear that. What did you say?
Urology.
Urology. Okay, sweet. Angela?
Angela from vascular.
Vascular surgery, sweet. Anne Yin.
Hi, I'm in urology also.
Euro, sweet. Now Ashley. Is Ashley there? Next, suivant. Catherine.
Hi, I'm ENT.
ENT, sweet. Drew, I know this guy. Ahmed, I know this guy. Joshua. Is Joshua there? I think he said cardiac surge. I came in when he was speaking. I think he's cardiac surge. And then I have Muad, Nawaf, Paul, Rayana, Asayeg.
I'm doing ENT.
Super. Raya, Conchi?
Hi, I'm obstetrics.
Super. And then Salim? Absent. Samar?
Hi, I'm Obstein.
Superb. And then where am I? Simon? Yasser? Yasser, what are you doing? Something else. And Yusuf Al-Mutawa?
Hello, I'm doing general surgery.
Superb. And finally, Sarah Al-Benali. Not there for now. Okay, super. Good guys. So you're good to go. So I was asked to do a little pre-exam review of ATLS. I think ATLS, I would say ATLS, ACLS, and FCCS are, I would say, essential kind of certification for your R1. FCCS, I think, is a really good one. Did you guys do it already, or it's later this month?
We did it.
You did it? Okay, so FCCS is really good for ICU. I think we're lucky you guys do that because other universities don't necessarily have the funds for all the residents to do it. ACLS, obviously, any resident should master it. And ATLS is really important in surgical specialties, especially for the trauma rotation, emerge rotation, general surgery. Ortho, we're always, by definition, our ortho call is a traumatic situation. So for sure, we're exposed a lot, and you should keep that in mind. So what I'll do, I'll just review, and you guys, I guess, should know that. So I'll try to make it as interactive as possible because these Zoom presentation can be really hard and painful. So I'll try to make that interactive through some case presentation. We'll go over the primary survey, the adjuncts to the primary survey, and then the secondary survey. Why ATLS is important? Because it is really, really simple and standardized. So it's been going on for like 30 years, and wherever you are, if you get a trauma situation and you're able to go from A to E and just follow the protocol, you'll be fine, and you'll be able to have a systematic approach. And that systematic approach, it allows you to find some small stuff that you lose when you have an overwhelming situation. So definitely keep that in mind. And ATLS is really important because that standardized approach really gives you a good edge during that golden hour. In the ATLS book, they speak about the golden hour. The first few seconds, somebody in a big trauma and a big car crash can die from things that you cannot prevent. Aortic rupture, complete, I don't know, like high cervical spine injury that gives the patient like sudden death. But then if he comes to the hospital, that golden hour is really important to save a lot of his organs. So I'll try to stay systematic as well. So we'll go through all these steps of an ATLS sequence. Starting with the preparation, the primary survey, the adjuncts to the primary survey, the secondary survey, the adjuncts to the secondary survey, or I would always say this, the PAN scan, the reevaluation, and then you either choose to do the definitive care. In our centers, we are the tertiary center, so that's going to be you, or transfer if you're doing a rotation in Gaspésie or somewhere that you need vascular surgeons, you need neurosurgeons. And for each section, I will always kind of subdivide in 3 parts. You do your assessment, you diagnose something, and then you proceed with an intervention. All righty. So preparation. So I remember my first trauma activation. You're like, holy shit, what's gonna happen? Like, what is it gonna be? So you always think it's gonna be super impressive. So preparation is key because when the patient comes, you already have some information, and if you're prepared, you already have an edge on this patient. So instead of looking like this poor little guy, I want you to be prepared with your team, having some equipment, the roles are attributed, and you have a room that's ready at the general, you have the trauma bay, and you will almost already have the information. I'll use also a lot of acronyms, guys, so you can use these acronyms if you want to remember stuff. So the missed handover will always be mechanism, obvious injuries that the paramedics think the patient has, the vital sign that they had, and the treatment that was initiated for now. Okay, so primary survey. Let's go with, I'll pick easy. Okay, Amid, primary survey. What are the steps of a primary survey?
So first we'll go A, B, C, D, E.
Perfect.
So in A, we'll check the airway. if the patient is able to speak or not. I mean, I want to check if the airway is patent or not. So if the patient, I would say hi. If the patient say hi or anything, that means at least the airway is patent.
Okay, A is airway. Then
B for breathing.
B. Okay, yeah.
So I will check that. Yeah, but
we'll go in detail. So just stay general. So we'll go in detail. And then C.
Circulation. D, disability.
Yeah.
E, exposure.
Okay.
And
as any good orthopod, is there something else you forgot? Maybe in A that you always
yeah,
think of?
C color. Yeah, C color.
Perfect. So A is basically airway plus C spine, breathing, circulation, disability, and exposure. Okay, so we will keep that same structure I told you about: assessment, diagnosis, and intervention for all of those. So airway assessment, Drew, what are you assessing during an airway?
You're assessing patency and I mean mostly patency and if they're oxygenating.
Okay, oxygenating, I would more put it in B. For me, airway is the tubing bringing the oxygen to the lungs, and B is the oxygenation process, which is the oxygen transfer. So is the air going all the way down to the lungs? So being systematic, think of anything that could block the air going down to the lungs, and that's your airway assessment. Okay, so you have a messed up face like this. Obviously, like we said, we keep the C-spine inline traction with this. But okay, then so we'll try to just find some findings that you could have during an airway assessment. Who's there? We'll go Abdulmajid Albelushi. What can you find? Diagnosis you could make just during the airway assessment? Or Catherine. Let's go with Catherine. I think she was ENT.
Well, so you did mention facial fractures or things that could potentially prevent, limit the airway patency. Certainly, if you're thinking of a burn victim, there could be some signs of inhalational injury.
Super, that's good.
Also, just a low GCS, so someone who has an altered mental status and is not able to protect their airway.
Very good. That's like already 3 diagnoses, and keep it simple. Like you're saying, like I'm an orthopod, I won't go hard on you guys. It's really simple stuff. If you have an obstruction, blood, vomit, teeth in the mouth, that for me is a diagnosis. You know, you diagnose that the guy is obstructing, he's full of secretions. You have to think that, because then if this is your diagnosis, you'll need to do an intervention. So I totally agree. If you see pharynx that is burnt, if you see massive facial fractures, if you see like a big laceration on the neck, that's all diagnosis you can make. Okay, so good. So as Ahmed said, if like the first thing I do when I was doing your rotation in general surgery, I was ready, I was wearing a gown, and I used to go and wait for the patient off the ambulance, and I would just ask the patient, okay, buddy, what's your name? I'm Julien, the resident in trauma. And then first, if he's able to talk, even if he's in pain, he's screaming, if he's able to talk, you already know that A, B, and C is okay. If he's talking, you know the airway is patent. Breathing, well, you get the vital signs, but most probably he's breathing okay, like he's not crashing right now. And circulation-wise, he's able to understand you and answer a question. So you already know he's vascularizing and he has oxygenation to his brain. So talking to the patient is the first good thing you could do. And the guy is still walking with the paramedics, and you already know that your area A, B, and C is okay. So that would be my first personal trick. Go and get the patient to the ambulance, walk with him near the stretcher all the way to the trauma bay, and then talk him to him. Meantime, you have any shortness of breath? Where's your pain? Oh, my pain is around the pelvis or my leg. So, okay, you're good. A, B, C is fine. And then inspection. So mouth, pharynx, and neck, like Catherine said, that's perfect. Debris, wounds, facial injuries. And then you can evaluate already your airway. So another good acronym is LEMON. You'll see that in your ATLS protocol. So you'll look, you'll evaluate your distances that I always forget, but overall, you just have to see if the patient is like a short neck and obese, or if he's a standard, easy to intubate patient. Ideally, for sure, you'll open the mouth, see if he has a malampathie that is bad or good for intubation, see if there's obstruction, and neck mobility according to the circumstance. And always, always, always maintain cervical precautions, because in traumatic situation, you can never Well, I mean, you can overlook the cervical spine injury and you can do some pretty big damage if you overlooked it and neglected it. Okay, so now we assessed, we diagnosed, and what are we doing? During the airway, what are intervention? What was that? Okay, that was just other findings. So tongue obstruction, foreign body burns, as Catherine said. Okay, hematoma. So interventions, I'll start with a definition that you will always hear in your ATLS. I'll go with Paul. What is definitive airway, Paul? Is Paul there?
Yeah, I'm here.
Oh, right. So what's a definitive airway? They'll say, okay, patient has a definitive airway or patient needs a definitive airway. What's the definition?
When you establish when you've established an airway, like you can maintain one, you know it's open.
So is a LMA or somebody with a GEDED, which is an oropharyngeal adjunct, is that a definitive airway? So basically, I'll help you here. So it's a tough one, but definitive airway, technically you need to have a cuff inflated below the cords. You need to have a secure O2 source. And that is usually the things you need. So it can be a surgical airway. It could be just a normal intubation endotracheal airway. But the thing to remember, it needs to have a cuff below the vocal cord, an O2 source, and a secured tube. Until you do that, you don't have a definitive airway. So even if the moral is, if you have somebody that needs an intubation, it's not because he's saturating okay when you're bagging him with nasopharyngeal airway or a jaw truss or something to help, that he has a definitive secured airway. Okay? And so you'll hear that term all the time, but just to keep in mind. And then intervention that you do in your A, so cervical collar, again, don't forget, suction. It's stupid, but it's super helpful. If there's full of secretion, full of blood, you want to see if there's teeth all over the place. Then you can already put a mask, 100% on rebreather. If the patient has no drive, like Catherine said, you can bag. If it's a neurosurge patient with a big head bleed and he's comatose, you can bag him. Really, really important to practice. It's stupid, but you can save a patient, is the basic airway maneuvers. So chin lift and jaw truss, okay? And then other adjuncts are just the cannula I spoke about, either the nasopharyngeal or the oropharyngeal. And then rarely you'll have to do it because you always, at that point you have some help, is intubation. For intubation, there's always either the emerge doc or the TTL or somebody, the fellow is around for intubation. And whenever you do intubation, you need to have backup. So if your normal endotracheal intubation with the scope doesn't work, you need to have a backup. So either a glide scope, a bougie, and if nothing's worked, you can just put something temporary like a LMA, okay? And then if you have somebody, like Catherine said, that has crazy facial fractures, you can already think, oh, I might need a surgical airway. So some of you might, I don't want to say lucky, but it's good exposure, because once you do that in a really crashing situation, it's a good skill and it's a good thing to master, to think of a surgical airway and do either a crico or a tracheo. In ENT, obviously, you guys will do tons of those. Okay, that's good for airway. Usually airway is pretty straightforward because the patient often has a patent airway. You kind of suction a bit, do the basic maneuvers, and you're good to go. So breathing assessment. Let's go to Ria. So what do you assess for the B, the breathing?
Hi. If you have an O2 sat pro slide, you could put it on.
Perfect. That's like the best thing you can do.
Look at their chest, see if like they're breathing equally. If you have equal rise on both sides, listen to the lungs. There's decreased air entry on one side.
Yeah.
What else? I don't know if like looking at the skin, if that's more circulation, like if there's cyanotic.
Yeah, it's a good point, but I would also put it more with circulation. Plus, it's a bit, keep it simple, you know, looking at the tip of the fingers to say it's ATLS. It's really simple. Like you said, is he satting? Like, this is the best thing. People forget. Look at the vital signs. The vital signs tells you everything.
Rest rate, yeah.
And then chest rise. Another thing that you can see with the chest is looking at the pattern of respiration. Do you have a flail chest that has some paradoxal movement? Do you have somebody that is working hard to breathe? You know, that's some tirage. So all these things are diagnosis you do in breathing assessment. You look for bruises, signs of chest trauma. So these are all things that go with B. But the most important thing, saturation. Okay, take your vital signs. The first thing the patient will have when he's arriving in trauma is get some regular vital signs. You tell, okay, trauma nurse, please hook the patient up to a monitor, get some blood pressure every 5 minutes or every 2 minutes, and get a SAT probe. That's it, and you're good for your breathing assessment. So as you said, saturation, respirate. If you see somebody that's really struggling to breathe, most probably has a problem with the B. Physical exam, you want to expose the chest, right? If there's a seatbelt sign, you want to see if there's rib fracture, if there's a big hole because the guy was attacked by a tiger. You have to remove the clothing and see what's up. You look at the neck, chest, and abdomen. And probably the only time I used my stethoscope since med school was during trauma, because you do make some really good diagnosis for the B, breathing with your stethoscope. When I told you I was waiting for the patient at the ambulance, when I'm walking, you can already auscultate both lungs. And if you know the SAT is around 88 and you have no air entry on the right side, you already know you're going for a chest tube. You know, so these are kind of stuff you can diagnose really rapidly in your primary survey. Palpation, really key. You can have subacute emphysema. And so basically these physical exam or assessment will allow you to do some diagnosis. So you have some diagnosis to think of in trauma, hemothorax, tension pneumo. You'll read in the books about the tracheal deviation and stuff like that. I never saw that. If you're really keen on your physical exam, you might see that. Keep on simple stuff like there's no air entry on the left side or right side. Well, probably there's something wrong on this side. Open pneumothorax, you'll see that sometime, penetrating injury or big trauma. And flail chest. Flail chest is pretty obvious. You'll see paradoxal movement of the chest wall. Okay, and then simple intervention that you can do for the breathing, put some O2, right? You'll see if it's like a mild breathing problem, you can correct it with either just a nasal prong or a mask. And then if you're thinking of hemothorax, tension pneumo, you're talking about the decompression or a chest tube. So is Joshua there? He's like cardiac surgery. He'll tell us how to do a perfect chest tube. Joshua, you there, man? Not sure. Okay then. Angela, how do we do a chest tube?
For the chest tube, I think you can go in the interaxillary line and the 4th to 5th intercostal line.
Yeah.
I think you can also do finger exploration before the chest tube insertion if you are in an emergency situation or if you don't have all the equipment.
Yeah, sure. And you kind of have some cues here on my screen, but do you go above or under the rib and why?
So you would go above the rib because the neurovascular bundle, while the nerves are running under the ribs.
Exactly. So a good trick is to kind of, for a man, it's easy because there's no breast, but usually it's a nipple line is the 4th or 5th. You do a skin incision, be generous. It's trauma, patient is dying. Don't go MIS there. It's like do a big incision around 3 or 4 centimeters. And then you're gonna go with a Kelly or a finger and palpate the ribs. And if, let's say, I'll try to see if I can do some markings there, but let's say your skin incision is around where it's written 5th intercostal. That's usually what I did. I did a skin incision there, and then you walk a bit like this figure. You walk, let's say the skin incision is here. You can walk your Kelly all the way up a couple of levels to make sure first that you're above the rib and first that you went up a couple of levels. Because I think my first chest tube, I was like an inch from the liver. So you want to stay high and make sure you're not like skiving a diaphragm. So you do a skin incision, you walk a couple of levels, you find your level and you pierce it. It's kind of hard, you'll see. You need to really pierce it hard. And once you're in, exactly like you said, finger, you detach the pleura and you make sure you have the good spot, and then you insert your tube, aiming posterior and superior like you guys had in the last talk. And you do insert a while. You can go around 20, 25 centimeters and then you secure the tube. Okay, so that's in breathing. So you're still in primary survey, but you've done all this for now. Okay, then C goes shock. C for circulation, and you assess some causes of shock. Who's in vascular? I already forgot. Anne, huh? Was it Anne in vascular? Anne? No.
No, I'm in Euro.
Oh shoot. Who's in vascular?
It's Angela and me, Sri.
I didn't hear that. But whoever's in vascular, tell me what is a shock.
The shock is a demonstrated dip in someone's BP. So it's a lack of perfusion.
Okay. Would you say somebody has a low BP is a shock? That's kind of important because you told me it's a drop in the BP. Would you say somebody who's hypotensive is automatically in shock? Or somebody that's normotensive is not in shock?
Well, I think the key is perfusion. So if they're not able to perfuse their tissue, they're in shock.
Very nice, my friend. And I would just add to the definition that the shock is at a cellular level. Okay, so it's hypoperfusion or not well oxygenate cells. Okay, it's not necessarily just the blood pressure. It's a problem of oxygenation of the cells. So what are the shocks you need to think in trauma then? What are the shocks, or categorize, or keep it really well categorized? What are your category of shocks and things you could expect in trauma?
So hypovolemic, cardiogenic, distributive,
Sure.
and neurogenic.
Perfect. So these are the categories. Well done. And what kind of example or diagnosis you would fit into a trauma situation? So you told me distributive. Would a septic shock be in there for you? Not really.
Yeah.
So tell me the high yield trauma shock.
So hypovolemia, loss of blood. Cardiogenic, where you may have a tamponade and you're not able to pump out any blood or have low cardiac output. Then you have septic shock, and in someone with a high spinal cord or brainstem injury, you could have a neurogenic shock where they're not able to maintain adequate vascular resistance.
Perfect. And one last category, I would tell you that you already said that category, but in the wrong one, in a sense that cardiogenic for me is rare. Cardiogenic per se would be a cardiac contusion. The guy has arrhythmia and there is cardiogenic shock. The one you described, the tamponade, what type of shock is that? What's a tamponade classified? Is it cardiogenic or it's another category? Somebody else could jump in if you know the answer.
Obstructive.
Exactly. So tamponade and tension pneumo are more of an obstructive type of shock. Who cares? It's only semantic. I just wanted to clarify this with you guys. So the least common are septic. Somebody can come in septic with a trauma. Poor guy, not lucky, but often there's no septic shock in trauma shock. However, cardiac contusion, I've seen couple, but not many. There's nothing to do anyways. You'll just monitor. But definitely the rest, all the other ones. So hypovolemic or hemorrhagic shock, obstructive, really common. And then distributive, us in ortho, we see it a lot with the spinal cord injury, as you said, for distributive shock. And we call that the neurogenic shock. Sweet, good job. And then signs of shock, you'll need to study these class 1 to 4 with the level of blood loss. Just remember that initially you can have a significant loss of blood without any clinical signs. And then I would tell you that the most, like a good sign would be tachycardia. It's not like just 100 and he's in pain. It's like real tachycardia to like 120. The guy is calm, but he's still at 120. You're like, something's wrong. And then once you go up, you'll get some confusion. That's a really cool feature when you find it. The patient really looks like confused. He's a young 35 years old that had some, scooter accident, but he's really confused. You know what's going on. He didn't get any drugs or alcohol, but he looks like it. But sometimes just because of the blood loss, you look like this. So that's class 3. And class 4 is when we get blood pressure, you're dropping, that's going bad, okay? So assessment, again, vital signs, super easy. Is he tachycardic? Is he dropping the pressures? Is he confused, like I said? And then we're talking about now the skin perfusion. And obvious external hemorrhage is a good sign as well. If the guy's leg is completely mangled and he's pissing blood or arterially, you know he's probably in shock. And in trauma would tell you that the first decision is to think, is the blood pressure abnormality or the shock because of a hemorrhagic cause or non-hemorrhagic? So my really good trick, I don't remember who told me that trick when you do a primary survey, is to think of the floor and 4 more. Okay, so remember that, guys, floor and 4 more. So you look for an external bleeding, because you'll see a trauma bay, it's messy, people screaming all over the place, you know what's going on. You look for external bleeding. So you expose the patient. The scalp, I would say, something is often forgotten. Everybody looks at the mangled leg or the pelvis or the penetrating injury, but they forget that the scalp is bleeding out. Okay, so that would be a good one. And the chest, you have to think that the chest could contain like a couple of liters of blood if there's a hemothorax. Abdomen, our gen surg friends will tell us like spleen injury, liver injury, it bleeds a lot. So you have to think of this. And it's pretty easy to do. The chest, we already went through, you listen to the chest. Abdomen, you touch the abdomen, is it peritonitic? Or you do your fast. The pelvis, is there pelvic pain? That's it, you just touch it, you suspect it. There's nothing you shouldn't do, have an x-ray vision and diagnose it right away, just suspect it. And then the long bones. If you see mangled leg, you can already think of long bones as a reason of blood loss. And as you perfectly said, these are the trauma shocks for me. Hypovolemic for hemorrhagic, obstructive including tension pneumo and tamponade, cardiogenic rarely for contusion, and then you can still have distributive with neurogenic shock or septic possible if the guy's really unlucky. Okay, so now we just assessed for now. What is this? Okay, again, yeah, floor and 4 more. Remember that, guys. So hemothorax. Here we got, I think it's on the spleen side. We see the spleen is bleeding. Open book injury, bleeds like crazy, and long bone, femur fracture, high velocity injury can bleed a lot. So think of this when you're assessing for your hemorrhagic shock. What else? Okay, so in C, you diagnose this. You think the patient has a long bone injury. We'll see Simon. Okay, Simon. So the guy has pelvic fracture, femur fracture, open. He's bleeding from his scalps. So what do you do in C circulation? You're still in your primary survey. Go ahead, Simon.
So not in treatment, primary survey?
Yeah, we talked a lot, but we're still in primary survey. The guy's he's okay. He's breathing okay. He's satting around 90. His chest air entry is bilateral, but you're looking at the scalp. It's bleeding like crazy. He has pelvic tenderness, and you see bone sticking out of his femur. So you're technically still in primary. You just told me that he's satting okay. So you're still in circulation. He's tachy, and blood pressure is like on the low side.
So I would see if there's a pulse distally to the injury.
Whatever. The nurse will tell you, oh, a faint pulse but weak. Intervention. I want actions. I don't want assessment. I want intervention, action that you actually do to treat the guy. Yeah.
First of all, you're gonna ask for blood units. You're gonna push a bolus of at least 1 liter, probably 2.
Perfect. Through what? You push the bolus through the skin. You need 2 IV lines, right?
Yeah,
so
you need 2 large IV bores.
Exactly. This is like a cassette. Whenever you're doing an ATLS, you're like, okay, I'd like to have the patient on a monitoring with blood pressure taking every 2 minutes. I want 2 large IV bores. I want blood product prepared. Okay, and then continue. What else you do with that type of? I told you scalp, pelvis, and long bones.
So you want a pelvis binder or try to reduce the fracture to limit the bleeding.
Very nice, really important. And then
scalp. The scalp, you can just apply a dressing or apply pressure to try to limit the bleeding also.
Excellent. Stepwise approach to external hemorrhage would be pressure. And then you can always, if it's the scalp, you can have some staples. You can staple the guy, but usually just pressure is good. Same thing for the leg. And what else with the leg could you do? For now, you address 2 out of 3.
So we're at exams now, so I would need an X-ray of pelvis and the leg.
Yeah, but intervention, even if it's in primary survey, you'll reduce the long. You can just pull on it just rapidly. Don't do anything crazy in a complex cast, but align for me. Long bones, if it's bleeding and putting out of length, is also an intervention you can do in primary rapidly. Okay, so but most importantly would be external hemorrhage to put pressure. Putting the pelvic binder can save somebody's life. and then putting your at least a liter of crystalloid. And if you're suspecting like a significant shock, you can already give 2 liters and ask for bloods. Okay. Good. So BP monitoring, it's like your cassette. You start your cassette. Okay, BP monitoring, 2 large IV. If I don't have any access, I think of an interosseous. I think of a central line. You'll see Dr. Bracco. You didn't even finish your airway breathing, and there's already 2 central lines in the guy. You'll see that. And then you'll see you give crystalloid, and then you stop evident bleeding. Like I said, pressure, packing, proximal control. If it's a really mangled leg, you can put a tourniquet. Pelvic binder, reduce rapidly fractures, and then you get the labs as you said, and you transfuse blood after the first 2 liters. Good? So that's still primary survey. That's an example of a pelvic binder I applied during my R1. You see here the pubic symphysis diastasis. There's clamps that the other hospital, they tried to apply the binder, but obviously it wasn't good. So if you apply properly on the greater tuberosity, greater trochanter, it closes nicely, and you can reduce from significantly the venous bleeding in the back of the pelvis. Alrighty. Okay, disability. Who's in neurosurge? Who's neurosurge? I heard somebody say neurosurgery. Is there anybody in neurosurge, guys? Neurobrain? I thought I heard it. Okay, anybody then? Drew, what are you doing for D for disability?
You're gonna check like a Glasgow Coma Scale and just
Perfect.
do like a check, like a routine neurological exam or a simple neurologic exam.
So you told me Glasgow, gross motor, like neuro exam, just want to see if the guy's paralyzed. And what else would you check for our neurosurgical friends?
Like quick sensation exam.
No, I would say the pupillary exam. You want to see if there's a blown out pupil. So yeah, okay. Pupils, Glasgow, and gross motor or sensory exam. Okay, I would tell these are my 3 things I would say. So Glasgow, try to remember it. You want to see if there's localization, if there's really something wrong. And pupillary reflex, you want to see if the patient is engaging or there's a blown out pupil on one side, okay? Because then you need to talk to the neurosurgery team. Good? Good. So finding diagnosis, you'll think of traumatic brain injury, spinal cord injury. You have to think of some mimickers that people can show up with hypoglycemia, alcohol, or other intoxication. An intervention that you can do in your D is, I think it was Catherine initially who told us that if the patient is not protecting the airway, by definition with a low GCS, it's an indication for intubation, okay? And if you think of a traumatic brain injury, the rule is to prevent secondary injury by having a perfect oxygen level, a perfect blood pressure. So you want to oxygenate and allow some good, I'd say, parameters for the brain to recuperate from that injury. Obviously, you want to have a CT head. If you suspect a TBI, that will be in our adjuncts later on. And you want to keep the spine precautions if you think of let's say, a thoracolumbar spine injury. Like we kind of touched it in the previous talk. You guys talked about the bladder and everything, but what would be, is Muad there? Muad is there, yeah, Muad. Muad, tell me, what is the difference between a neurogenic shock and a spinal shock? Because you'll hear that all the time.
Yeah, so neurogenic shock is when there is injury to the spinal cord, and it manifests with both motor and autonomic symptoms, whereas spinal is, I think, mostly autonomic. And it happens post-injury. So the patient will persist with the signs of lower motor neuron, while it is an upper motor neuron.
Yeah, so it's kind of the definition. I would tell you that the neurogenic shock is a real shock in a sense that you're assessing the blood perfusion and the oxygen perfusion. So that was the autonomic dysreflexia that you talked in the previous talk. So this is really because of the blood vessel. They don't have it's like a septic shock finally. You don't have the vasoconstriction to keep an adequate pressure. So you treat a neurogenic shock with alpha agonists, right? Versus a spinal shock is a ortho nomenclature to tell us that yes, it's a spinal injury, but it looks worse because the cord is stunned. So the cord will be, the patient will be flaccid in the first couple of days because of a spinal shock, and then the injury will demonstrate itself after a couple of days. So in trauma, you should talk about neurogenic shock and not spinal shock. Spinal shock is not really important in the first couple of hours. Okay, so if somebody uses spinal shock, correct them. It's neurogenic for trauma. Okay, and then you're at E, exposure and environmental control. You want to undress the patient, remove all clothing. You want to check if there's other signs of injury that you forgot. The log roll at this point will be done, okay? And during the log roll, you will do the spine palpation. The spine palpation, basically you're looking for pain and you're looking for a crazy deformity that would suspect you that there's a big dislocation in the spine. And you'll proceed with a rectal exam for blood. If there's penetrating injury, that could gives us clue, and for sphincter tonus, okay? And at that point as well, you'll check for hypothermia, you'll put some warm blankets, and you'll remember that if the patient is cold, it encourages a coagulopathy, and therefore you'll continue the hemorrhage orbit, or you'll just not help the correction. So that's the primary. The primary will be done all of this when you'll be good in 2 to 5 minutes. If there's a lot of intervention to do, intubation, it's going to be longer. But usually for, let's say, simple polytraumas like you'll have most of the days at the general, this you'll go through it rapidly in around 3 to 5 minutes. Okay, so what are the adjuncts afterward? First of all, is there any questions from A to E? A, B, C, D, E. Is there any questions?
Yeah, what is the role of tourniquet in the trauma setting?
You tell me, what is the role according to what we said from A to E?
Yeah, I know it will control the bleeding, but do we really do it in the practice or only will do compression?
Absolutely. So what would be your criteria? I think we'll talk about it lower down in a case, but what would be your criteria of applying a tourniquet? So gunshot wound around I'd say the popliteal region, you're putting pressure. You keep your hand there, what's going on? The blood pressure is still low, he's still tachycardic. CIMO did a good primary survey, gave you blood, but the patient's still not doing good, it's still out of bleeding. Would you put a tourniquet?
Yes.
Yes, perfect. Yes, so tourniquet, you should use it. If there's a really mangled extremity, you don't have control of the bleeding with standard measure, you should think of a tourniquet. And I think it's basic stuff, but it's one of the skills that ATLS will like you to practice. So putting a tourniquet, it's stupid, but it will save a life. And even I would tell you that in the military, it's not A, B, C, D, E. The first thing is C for hemorrhage. If there's an obvious external hemorrhage in a case, you should almost attack this like a severe hemorrhage. You should attack this right away with a tourniquet or stop the bleeding and then go with ABC. But I think this is more for military. For you guys, keep to the ABC, but just keep in mind that yes, a tourniquet, for me, I placed it earlier as an intervention for, where was that? Did I place it? Yeah, tourniquet. So for me, it's an intervention in your primary survey already, a tourniquet. Okay, Ahmed?
Yes, thank you.
Okay, so adjuncts. Who's there? Ashley. Is Ashley there? What are the adjuncts to the primary survey?
Okay. So adjuncts could be like inserting a Foley catheter,
Sure.
to monitor urinary output, or you could put in an NG tube to decompress if you feel like that's contributing to the situation.
Sure, that's always good. I would tell you that people will always put the Foley as a last resort. But what else do you do after you, because for now there's no x-rays done, there's nothing done, right? So you just log roll the patient. After the log roll, usually what happens, you know, if you've seen a bit of trauma, usually there's x-ray that are taken, right? So you'll have chest x-ray and pelvic x-ray. These are the standard classic adjuncts to your primary survey. And nowadays, you always have an ultrasound bedside, and technically, the fast ultrasound is done during this primary survey as an adjunct as well. Some will do it at the same time of their C. For me, I would complete your rapid A, B, C, D, E, then do the imaging with fast or chest X-ray or pelvic X-ray, okay? And yes, the Foley NG tube is there. So extended fast, chest X-ray, pelvic X-ray, cardiac monitoring, Foley, as you said, NG tube, good? So at this point, you kind of imagine a situation. We'll go through a situation, but imagine the guy. It's not dramatic like this, because this for sure would alter his saturation. Somebody with some sort of signs of chest trauma, satting 92, and then okay, we gave him a mask. He's satting like 93, 94, but not perfect. He's a young guy. He should sat okay. You get to the adjunct, and you see that. Let's put a chest tube. Okay, so that's the sequence. Keep it really a nice sequence, like ATLS protocol. Okay, and then you go to the secondary survey, and usually another acronym would be the AMPLE acronym. So at that time, you'll get some infos. Allergies of the patient, his age, his medication, his past medical history, the last time he ate something, and what happened. So you'll get that info usually after your primary survey. And then you do a physical examination from head to toes. In ortho, we call that the ortho massage. You get all the joints, you move all the joints, you flex, you see if any poking, any signs of bony injury. That would be at this point. And our rule is usually whenever there's an abrasion, laceration, get an x-ray, because you don't know what happens. Maybe there was a rollover, it could be injury to anything in the body. So that's your secondary survey. And with that list from head to toes of suspected injury, you ask the according imaging or the according adjuncts to the secondary survey. And that will be usually PAT scan. So physical exam is important, right? So, I mean, these are obvious injuries, really obvious injuries, but sometimes it will be more discreet. And yes, it's easy to do a PAT scan, and the radiology resident on call will find you your injury. But it's better if you actually examine the patient, you kind of suspect the injury there, and you ask the appropriate imaging, okay? So at that point, the patient will go to PAT scan. And you consult the appropriate service, like neurosurge for that epidural hematoma, gen surge for that penetrating gunshot wound, whatever ENT or gen surge for that neck laceration, and you ask the ortho guys when you see the ankles or like that. Okay. Any questions for now? All good? Okay. So we'll go through some cases to illustrate the simple stuff we discussed, okay? So I want you to really be systematic, go through your A, B, C, and if you stay with that same sequence we discussed, you will never forget anything clinically and in your exam. Good. So let's go through a first case. Who's there? Nawaf Alamiri. Let's do it. Okay. So 22 years old, was riding a bike, lost control, fell off, no helmet. At the time, he talked to his friends, I'm fine, guys, I'm fine, but he still came to the hospital. Since then, he's vomited several times, and basically now he's a bit more wobbly, a bit more confused. Vital signs for now by paramedics are heart rate of 88, blood pressure is fine, satting 96 on room air, and rest rate of 16. For now, no treatment done. On initial airway assessment, the patient was able to speak, was not breathless. So what's your sequence for now? You just had this report from the paramedics.
So basically from what I see from the paramedics, that they gave me A and B have been done, but I would also confirm it. So I would, I will secure his airway.
Mm-hmm.
And his breathing appears to be normal.
Mm-hmm.
So I would jump to circulation. I would ask to have 2 axes of 2 peripheral lines. And, and then I will check to see if there are any disabilities. And of course, I'll finish it by exposing the patient.
Yeah.
See if there are any other traumas, maybe in his back or his legs or anything. Yeah. And after that, I would go to the adjustment and check for to do the tests, basically. Yeah.
Perfect. Okay, so that's your primary. So in a simple case like this, it's going to take you a minute and a half, 2 minutes. Okay, so you did it perfectly. There's maybe one thing that you forgot. I don't know if somebody picked it up.
C-collar?
C-collar, yes, C-collar always, especially with an unclear mechanism. Okay, so the rest you did it fine. Patient comes in, the vital signs are good. You don't hook him up on a non-rebreather if the saturation is okay. It's 96, not perfect, but the rest is fine. So I agree with you. You spoke with him. He's a bit confused what he's speaking. So you know A, B, and C are fine. Okay. Yeah. So let's see what happens. So he's not in distress. His eyes are closed. He's responding. He's not responding to speech, and there's no. He is not responding to speech. Okay, and there's no obvious facial injury. There's no added airway sound or something crazy with the chest, and there's some fogging. However, the patient is snoring now. So he's a bit drowsy, and he's snoring. So what is snoring indicating for you? So basically a good lesson also, I don't know if I told you guys, but you do the primary survey, and whenever there's an abnormality, you go all over again. So now you see he's being less confused. So it's a dynamic process. Maybe it was fine 5 minutes ago, but now he's confused and he's snoring, and he seems like he's less reactive. So what do you do? What is snoring indicating for you?
So the patient's status has been changed. So I would repeat the process: airway, breathing, circulation. And through airway, the patient, as you mentioned, is snoring. So that indicates that maybe his epiglottis is falling back in his on his trachea, thus causing like maybe difficulty of air entry. So my option is basically to secure his airway.
Perfect. How would you start? You're alone. It's 2 a.m. You went to see this kind of, initially it was a small trauma, right? So you're alone in trauma bay with the trauma nurse.
Yeah. So I would go with jaw thrust.
Very good. How would you like to do a jaw thrust? How do you do a jaw thrust?
So basically, I put my 3 fingers behind his jaw and then securing. I don't know how to explain it, but by holding and putting pressure on his jaw to make it like protrude, and then lift up a little bit.
Yeah. So there's kind of two things you can do. Little chin lift, make sure he's not like chin to the sternum. You raise the chin a bit, and then as you said, bilaterally, you put your finger on the mandibular angle and you bring the mandibular outwards, and that's the jaw thrust. Okay, perfect. It relieves the snoring. So your diagnosis was perfect. Great job. But then you're still alone, and you need some help there, right? So what else are you thinking right now? He's still confused. The GCS is going down. So what else are you thinking you'll need to do? So as I said, jaw thrust relieve the snoring. But whenever you go back to check your iPhone or to text your senior to come and help, the snoring reoccurs. So what next? What are your options?
Okay, so call for help. So first
definitely. So senior's coming. He's stuck in the MGH elevator. What next?
So I'll keep on maintaining his airway and breathing. So
sure. So airway, basically my pretty bad question, I guess, but what's the next step? You did your basic airway maneuvers. What is your next basic airway intervention we discussed that you can do? I kind of went rapidly over it, but what is something that can bring you a temporary straight airway shot while bagging, let's say? Anybody else can jump in if you know the answer.
Oropharyngeal tube. I don't know what it's called, but just like an adjunct, like there's a nasopharyngeal one, oropharyngeal
exactly. Either oro or naso, but that's a good one to put it at that time. And it will give you a straight shot if it's only tongue obstruction or soft palate obstruction. It will give you a straight shot to the airway. So I would definitely at that time ask the RT if she's not there. She should be there. It's a trauma activation. But if you're alone, think of it. And it seems silly, but at that time, you'll be stressed out putting that in the mouth. So remember your basic measurements. If it's nasopharyngeal, you take it from the nose all the way to the ear, and then that should be a good orientation. And same thing for the oropharyngeal. So definitely insert that with some lubricant, and then your bagging will be more efficient. And let's say the RT comes and she's like, oh, wow, good job, guys. You put this already. Okay, good. Next up, are you be staying like that all night, or what's your next step in your airway assessment or management? You're bagging the guy with some Guedel or some oropharyngeal adjunct.
Yeah. Well, I'll keep bagging him, right?
Okay. But then you need to assess some patients eventually, and the guy cannot be bagged by you. It's kind of silly question, but that's ATLS. So on reassessment, the breathing is only 6 by minutes because you're bagging him, but he's only breathing at 6. So what are your options now? You're still at A for airway. What do you need to do? Your senior's coming. He's like, okay, buddy, we need to do something. What are we doing?
So, still on that.
For now, you're just bagging. Again, it might seem silly, but anybody else would jump in at that time. What would you recommend to do?
Definitive airway.
Perfect. Yeah. So you want to plan for a definitive airway. The guy is failing to protect his airway as a low GCS. So these are criteria for intubation. So I would not expect you. I didn't intubate a patient by myself. You should never do that. It can really go wrong unless you're in a critical situation in the streets. But even then, the paramedics will be there and well equipped. So at that time, you can bag him with the RT, tell them to prep a definitive airway set with endotracheal intubation. You want to back up. You want a glide scope in case it's tough. You want a bougie in case it's tough. You want to think of all this, okay? And this is not a case that usually you'll need to think of a surgical airway, but hopefully you never get there. So you ask the emergency doctor to come, you ask the TTL to come because you want to intubate. And if they're not answering, call anesthesia. There's always an anesthetist on call. Good, so you want to put a definitive airway. So bag mask, we talked about it. Okay, definitive airway, we went through it. Indication, we went through it. And the tool you're using to determine the difficulty of intubation, anybody remembers?
Facial fractures.
Yeah, facial fracture, but the tool would be the Malampati or the lemon. You know, you remember these things. So the lemon, you look, you evaluate, you measure, you observe, okay? And the Malampati is always good to check. Are you having, so a good trick, what was the good trick? I think a difficulty intubate is like Santa Claus with a big beard, a short neck. Anyways, try to remember that. If you see an obese person with a short neck, you're like, okay, this is not an easy intubation, okay? So key points of this first case, basic airway maneuvers are simple, but they can definitely buy you some time, okay? And then it's a dynamic process. So even though the patient was fine initially, probably has a TBI, maybe a head bleed, and then was not protecting his airway. So you need to go back to your A and reopen it and use some adjuncts with either nasal or oral airways adjuncts. And then you remember how to back mask. Remember, you go read on your techniques for 2-hand technique or 1-hand technique. And then eventually you either use a definitive airway or some sort of temporary supraglottic airway like an LMA, okay? And then endotracheal intubation is complex. It's a high degree of knowledge. You need to have a lot of control on your medication for the intubation. And you need to have several different skills to perform safely. So don't worry, you will never have to, hopefully you should not have to intubate somebody alone as an R1 in trauma, okay? So just remember that. Initially you're afraid, you think you can do that. You'll see, you'll read on your meds, your whatever, propofol, succinylcholine, don't worry, okay? You should not have to do that. Just remember that, okay, this patient is going through a bad airway assessment, so probably we should intubate. And then that's already a good decision. Okay, second case. Who's up? Let me pick somebody. Who didn't speak? Samar. I don't think we spoke to Samar yet. Samar, you're there?
Yeah, I'm here.
Aha. Okay, good. Not second case is yours. So we have
Okay.
Mr. B. Okay. So Mr. B is the paramedic comes with their mist. Oh, I'm having some reverb. Okay. So the paramedic comes with the.
Okay, just 1 second.
Yeah, just turn off your speaker and then we can. When I'll stop speaking, it's gonna be yours. So the missed assessment by the paramedics is that he comes with a motorcycle crash. He was run over by another motorcyclist. So you're already thinking of a high velocity mechanism. He comes in and he's complaining of shortness of breath. His airway is intact. And that's our vital signs. A bit tachy. He's breathing really rapidly at 28. And he's satting 91 with oxygen. So how would you like to proceed?
Okay, so how much oxygen is he have? Is he on?
Okay, let's say he's on he's only on nasal prong. Okay, he's only on nasal prong 4 liters. It was the paramedic. So you're just walking into a trauma bay. This is your MIST report, the MIST report. What alerts you in the breathing issue? He says short of breath.
He's short of breath.
Yeah.
And he's tachypnic.
Yeah.
And he's tachycardic.
Yeah.
And his saturation is low.
Okay, so
those
how would you
are
like
all
to proceed? Go step by step. How would you like to proceed?
Okay, so first his airway, make sure that it's patent. Make sure the patient can talk. There's no like obstruction or anything like that.
Very nice.
Then B would be like his breathing. So the patient is tachypnic. Make sure that like if his chest wall movements, auscultate his chest.
Okay.
That's
Very
what
nice.
look at his trachea if it's like deviated or something like that. And then circulation would be like, well, his blood pressure is okay, but just make sure that there's no like external bleeding. Well, his blood pressure is a little bit low, but
Yeah, I agree with
Yeah,
you. His heart rate is 120 also.
yeah, and his heart rate's 124. So just put 2 IV cannulas in. Do a EFAST.
Perfect. You're allowed to do it there. Either you put it in adjunct or you do it there. But I
Okay.
would definitely start your cassette in your exam or in real life. Take some regular blood pressure. Give me 2
Okay.
large IV bores. Give me 2 liters of crystalloid.
Okay.
And okay. So always tell that. And I would agree with what you said. Don't forget in airway, this guy should have a cervical spine collar.
Yeah.
And other than that, in your breathing, I would give you your information that he has some sign of chest trauma on the right side, some crepitus under the rib cage, and he's on 91%, and he seems short of breath, but he's able to talk. So I would let you that the airway is intact. So good job. That took you 1.5 minutes. So great job. So airways intact. He has some rest distress. There's tunnel retraction. There's diminished air entry on the right side. And from the moment the paramedics transferred him to the, let's say, the trauma bay, now he's breathing 40 breaths per minute and oxygen drops to 80. How do you like to proceed?
I think he needs a chest tube.
Okay, very nice. Describe the procedure. How would you like to proceed? What would you,
Okay,
what would
so
you need? Everything.
what do I
Pretend you're
need?
there. Yeah.
Okay, so I'm assuming there's a chest tube kit. Or
Yeah,
no?
let's pretend let's pretend you're not at a trauma center and you can just clap your hand and say chest tube set, please. Just
Okay,
pretend you
so
need to create your
what
chest
do
tube
I
set.
need? Okay, so I need some chlorhexidine. I would need like like some type of sterile drape.
Perfect.
I'd need a scalpel.
Perfect.
I would also need a Kelly.
Perfect.
And I would need the tube, the chest tube itself.
Perfect. Which size?
What size?
Yeah.
36.
It's a really big chest tube, but usually 28 to 30 is good. That's a good guess, but it's a good. So I like how you kind of went systematically, right? You pretended you were doing it. So Clorox, sterile drapes, The guy's crashing, but sometimes you can put local in, right? But then when he's
Okay.
dying, you don't put local, you just go right through. But if you
Okay.
have time, you put local, so everything. Scalpel, ideally with the blade, so get your blade set. Sometimes you have disposable scalpel you can use.
Okay.
And then you get your Kelly and your 30 size or 20th size chest tube. Very nice. And how do you like to do your chest tube then? You have your material.
Okay, so you go for the triangle of safety. So I go at the level of the nipple.
Yeah.
And then mid-axillary line.
Perfect.
Between like right above the rib, I would make my incision.
Perfect.
Honestly, I can't remember how big it needs to be. But then, okay, then I would insert my finger to see where I am. Or dissect with my Kelly.
Perfect, yeah.
And
so
then
skin incision, Kelly dissection, you find your rib, you pop the muscle, intercostal musculature, and then you fall into the pleura, like you said.
Okay.
Finger decompression, make sure you're in a good spot, right?
Okay.
Good.
And then I would take my Kelly and like guide my chest tube in.
Okay, where do you guide it?
Upward. No, wait. Yeah, I would go upwards.
Perfect. Posterior, superior.
Posterior and up.
And that way you don't end like me near the liver in your first chest tube, okay? So you aim up.
I probably will hit the liver.
Yeah, exactly. I was aiming low. I think, I don't know. Let me find, maybe while we speak, I'll find the screenshot. I took a screenshot. I was laughing. Patient went well. Anyways. So, okay, perfect. And then you secure your tube and you leave it like that. You need actually to secure it to a Plurivac. Huh? Remember in your, Plurivac, secure it either with suction or not. Perfect. Okay, very nice.
Okay.
While we're here, I think Drew has a question. How fast does someone have to crash to do a needle decompression first? I would tell you that needle decompression would be in maybe in remote areas when you don't have access to it, because it's really fast to do a chest tube. So for me, I never saw it. I would tell you that when somebody is crashing, a little needle probably won't help that much. Could help a bit, but I'd much rather just put the big tube or just do finger thoracostomy right away. I don't know if I answered your question, Drew, but I would just tell you that I've seen, I don't know, like 40 chest tubes and never saw a needle decompression. So I would tell you that needle decompression is for remote or outpatient set, not outpatient, but like say you're in the streets, you can do a little decompression there. But definitely, if you have that indication, like in this slide, you put a chest tube right away. Good? Good. Okay, so let's continue your assessment. You know, the chest tube, we went that, we described. Look at that, look at your chest tube, it's perfect, okay? So that's great. And then that was still in your B, right? So you were still in B, breathing. So you redo your hemodynamic assessment. Then you get to the adjuncts, you get your chest x-ray, you see your chest tube is nicely placed. And then you do your secondary survey, your CT scan, because it's a motorcycle, so probably it's a weird mechanism, high velocity, needs a pan scan. And then you get your injuries and you get your definitive treatment. Make sense? Makes sense. Well done. What was this? Okay. Any questions for this case, Mr. B? No questions? All good. Okay.
I do have a question, yes.
Oh, go ahead then.
Yeah, hi. So if you put your chest tube and you're sure that the placement is correct, but then he's still desaturating, then you would intubate?
So answer that question for me then. So would you, so the intubation, the A and the B is different things, all right? So if you put your chest tube, let's say in that situation, you put it in and the guy is still not doing good. So what are you doing? You're restarting your assessment, okay? Because you are right, maybe it is because he's not breathing anymore by himself. So maybe that's why he's desatting. So look at your airway. Maybe he has no Glasgow anymore and needs some intubation. That's it. So that's one answer I could tell you. But what's another? You go back to your A. The guy is still talking, but he's short of breath. So now you're B. So B sequential. And at B, you see that, yeah, he's still crashing. And you look at the chest X-ray you just took, and finally there's a bit of pneumo on the other side. So you can put a second chest tube. So always go systematically and trying to find your diagnosis. Don't intubate somebody just because he's desatting. Intubate him because you have a reason, either low GCS, airways bad, or something like that. Sometimes even it's for agitation and pain control. We see that a lot for femur fracture or polytrauma. Even though the GCS is technically okay, if the guy is screaming all over the place, he's restlessness, sometimes you can do an intubation for agitation or pain control. But that's, let's say, more in a polytrauma or ortho-wise situation. But in your situation, go back to your A, assess the airway. If the airway is fine, don't intubate him for nothing. You can put a second chest tube and not intubate him. But I would tell you that if you need 2 chest tubes, the guy is pretty in bad shape and probably will need an intubation.
I see. Perfect.
Makes sense? So always just keep it systematically, do a diagnosis before doing a procedure. That's why I kind of wanted to organize the talk with assessment, diagnosis, and procedure, because you diagnose before treating, ideally.
Correct. Thanks.
Good. Okay, so key points of case number 2, stepwise assessment, as I said, knowing how to do a needle or more importantly, a chest tube insertion, and then proceed with the secondary survey, diagnose the final injuries and treat accordingly. Good.
I have a question.
Go ahead.
It's almost the same question that was just asked. Like, if we put the chest tube in, but we should have already established that the airway is patent. Then,
absolutely.
Then what's the point of going back and checking the airway if we already established it was patent? For a new obstruction, you mean, or something like that developed after we inserted the chest tube?
Yeah. What do you think about that from what we discussed in for now in the talk? Why would you go back? Because things can change, right? Things can definitely change. Like the first case walked in, he was speaking initially, the little bicycle crash, but then an hour later, probably bled more in his head or something like that. And now he became confused. Do you just assess him saying, oh no, his airway was okay 2 hours ago, the airway is fine? No, it's a dynamic process, right?
Yeah, I know what you mean, like even a swelling can develop or something like that.
Yep.
But what I meant was maybe the chest tube, maybe there was a problem that I did not notice while inserting the chest tube. Maybe I caused the difficulty in breathing. Like, when do I think about that?
Oh, definitely. I would go back to B. But if you inserted it, think you were okay, took the chest X-ray, and then he crashes again on the breathing side, my point is just quickly reassess the airway before assuming that it's fine.
Okay.
That's my point. Yes, you are right. Most probably it will be fine, but maybe not. Maybe he's polytrauma, and that's ATLS. You want to be systematic because you don't want to forget a small injury that you might overlooked, and that'd be a big problem. Let's say if he was finally not protecting his airway, and you go right away to circulation or breathing, well, you might lose the case, right?
Okay, sounds good. Thanks.
So so you're right. Reassess what you just did, but always go back to ABC, right? Restart rapidly, and it's really fast. You'll see it takes you a minute. Just look at the airway, speak with the patient, get the saturation, get the blood pressure and heart rate. That's it. And then you get your D and your E. Good. So why don't you go? Let's go continue with the third case then. I think your nickname is like Louis. Is that your name, Louis?
Louis, yeah.
Louis, okay, Louis. What specialty are you in?
General surgery.
Cancers, perfect, Louis. Okay, so that's your case. 32 years old, motorcycle crash, no helmet. Initially unconscious, right leg is mangled, left leg is kind of rotated, kind of wrong direction. Vital signs are tachycardic at 122, blood pressure 90/60, respirate 20, he's satting 89. His Glasgow is very low. Okay, so his airway already secured at another hospital with orotracheal intubation. The bleeding for now at the right leg is just a dressing. There's one IV and there's a cervical collar. He's secured to a rigid backboard. Okay, So this is a more of a little complex case, but we'll go through it. Keep it sequential, keep it systematic, and you'll be fine. So in your definition, would you say that the patient is in shock?
Yes.
Okay, so how would you assess the shock?
First of all, check for pulses.
Perfect.
And
so do you remember the little sentence I said to remember the cause of shock and trauma? Do you remember it was floor and four more?
Yeah. Look for
floor and four more. So what would
floor
be?
and four more.
Yeah. So go ahead. So go systematically.
Okay. So check for external bleeding.
Perfect. Done. Check. Next.
Okay. Try to control it if there is external bleeding, of course. First thing. Then try to secure peripheral IVs, two large bore IVs.
Perfect. And then the four more. What was the four more? What were the four other compartments that can contain a lot of blood? Do you remember?
The pelvis.
Perfect.
The
What else?
chest, abdomen.
Perfect. And one more.
The extremities.
Perfect. So that's how would you assess the C right away. We'll go back to ABC, but the C would be floor and four more. In this case here, there's for sure external hemorrhage, the mangled leg, the pelvis you can suspect, right? Because the leg is upside down, you might have an open book. And then you need to think about their chest as well. The SAT is 89, so that's not good. So these are all things to think of, okay?
Okay.
And then source of hemorrhage we just discussed. Okay, so how would you like to proceed? So let's take it back to a normal ATLS.
Okay, so first thing is the airway, because I think he needs a definitive airway, because he has an orotracheal. With the orotracheal, he's still his oxygen sat is low. So he might probably need a definitive airway, like endotracheal intubation or surgical airway, depending.
So that orotracheal intubation, they meant that there was a definitive airway. So that was already.
My bad. I thought it was
no problem.
Okay.
Because we talked about LMA before, but you are right. If it was an LMA, and most probably this case will come into you with an LMA from the paramedics, definitely I agree. Get the airway secured. Okay, good. So airway is secured, check. Now you can go to B. What's going on with B?
With B, I would check for chest movements. They're equal first by looking at the patient, and then I would listen to his chest for air entry, and I would percuss the chest, check if there is any dullness or hyperresonance, signs of hemothorax or pneumothorax.
Perfect. So I don't know what I put in the next slide, but let's pretend he has a bit like the last case, right? Let's pretend he has some right side chest wall abnormality, crepitus, and he's setting 89 with a mask. What would you do at that point?
So right-sided abnormality, what kind of abnormality in the right side?
No air entry, there's bruising, there's crepitus, and let's say there's paradoxal movement of the chest wall. So, when he breathes in, the chest goes in like a flail chest, you know? So what would you do?
Probably has multiple rib fractures, and this patient needs a chest tube on the right side to decompress.
Okay, that's what I want. So basically, that's what we did on the last case.
Yeah.
So now we'll continue. So your B, we just went over it because he's setting 89, but you did that. Great job. So now let's go to C.
Okay.
So C we already kind of discussed, and good job for you. You picked up that for now we had only one peripheral IV. You want a second one. You want a large bore IV. And what else are you doing in your C circulation assessment?
We want to check for like signs of shock, like pallor,
Perfect.
cyanosis,
Perfect.
capillary refills.
And what would tell you, let's say you received a bit of fluid at the other hospital or in his way, and he's still tachy 122 and blood pressure of 90. What would you say on this shock classification right away, only with these infos?
So you mean we gave him fluids and he still didn't improve?
Yeah. And his blood pressure is low. So you remember these, I don't, let's see, we'll go back.
He might need a blood transfusion.
Yeah, you remember here, whenever the BP is dropping, you know you're already in severe shock, okay?
Yeah.
Okay, just remember that.
Okay.
And yes, he already had, let's say, 1 liter of crystalloid or 2 liters. You know we need blood transfusion. Okay?
Blood transfusions, yeah.
Perfect. So, and then what else after C?
D, disability. Well, his Glasgow Coma scale is very low, so we need to reassess it again after we secure the circulation. Just check if he's improving or worsening, and we check his pupils for reaction and if they're dilated or not, and then the gross motor response.
Very nice. So probably the only thing you'll be able to do is the papillary exam, because as you remember, he's tubed now. Huh? So the propofol will. Well, is basically you won't be able to assess his Glasgow.
Yeah, he's sedated. Yeah.
Yeah, exactly. Okay, good. So that's you. He remains intubated, and then let's say we just added to the situation the chest tube, whatever. Heart rate. That's what we said. Okay. So on reassessment, now the stump dressing on his mangled leg is fully saturated, and the patient is still 90 on 60 with a heart rate of 120. So basically, you did pressure, and he's still dropping his hemoglobin, and you're suspecting what we said was a pelvic injury, and there's a mangled leg, and you already gave blood. Let's say you started the transfusion protocol.
And he needs an urgent surgical consult, or if the hospital doesn't have surgical capabilities that the patient needs, we need to refer him because he needs urgent surgical consult.
Okay, but then surgery, I don't know, you call Drew, but Drew is I don't know, he's not there. You call Simon, and everybody ortho, nobody's there. Okay, so who do you need, or what can you do by the meantime to help his blood pressure a bit? You already gave fluid, you already gave blood. You suspect a pelvic injury and a mangled leg.
We need to put a pelvic binder for his pelvis, and for his mangled leg, I'm not sure, maybe a tourniquet.
Yeah, absolutely. Yeah. If you have an arterial bleed, the pressure dressing's not working. You did everything. Eventually, it's a really bad leg. Like sometimes we have. I think I put a picture there. It's a recent case we had. I mean, let's see. Yeah, exactly. If you have a leg like this, and you see arterial bleeding, I mean, put a tourniquet. You'll need to stop this bleeding. And yes, again, the binder. Yeah. Good?
Yeah, good.
So staged approach to external hemorrhage and shock. Floor and 4 more. Remember that. When you have somebody, you'll say, okay, what's going on? You remember your causes of shock, and then you're all mad. You don't know what's going on. Remember, floor and 4 more for blood loss. Check the scalp. Check external hemorrhage like this guy. Chest, maybe has a hemothorax. Abdo, maybe has a hemopneumothorax, and then pelvis and legs. Okay.
Yeah.
Remember that. Okay. Good. And then this is more probably for. Go ahead.
I have a quick question. So I get that for extremity bleeding, we typically proceed in a stepwise fashion with compression and whatnot. But if you have a limb that's very threatened and that clearly, I mean, it's almost a complete amputation, and you're not thinking you'll be able to save the limb, is there any argument to just proceed with the tourniquet right away?
Oh, absolutely. I mean, I'm not sure if I got it right, but let's say you have this leg and you don't see any arterial bleeding, like you don't see anything arterial, but you're still dropping and you still see a lot of venous bleeding or something. If you could put a tourniquet, I mean, I think this leg, when it came a couple of months ago, to be honest, I don't think there was any arterial bleeding. I just made it easy for that case, but there was still a tourniquet on, if that answers your question.
Okay, yeah, it does. Thank you.
So if you don't know what's going on, it's a really bad leg or like a traumatic amputation. Traumatic amputation, often you'll have some sort of a vasospasm. So you won't have any arterial bleeding, or if it does, it will stop with the vasospasm or with a big injury or with the tourniquet. Okay, but yes, definitely, if you're not controlling the injury, think of a tourniquet for the limbs. It can save life. That you'll see there's posters in the corridor, and then the general about that tourniquet application. And just something to remember when you put a tourniquet, note the time, because you want to know the time of ischemia, the time of application. And then where were we? Okay, pelvic binder. Hamid, how do you put a pelvic binder?
Yes, so I need a sheet. So I'll be careful with manipulation with the patients. So that will go around the patient with careful of log roll, and that needs to be centered at the GT, both sides, the greater trochanter from both sides of the femur.
Perfect. Yeah, so centered with the GT, and often you'll see what is a really cool move to do when you'll be the trauma junior is when you think of a big polytrauma, the paramedics, they're freaking out. You can already place what is called a T-pod or that orange. I don't know if you guys know what I mean. It's like a pelvic binder, especially made. No need for a sheet, or if you don't have the T-pod, you can put the sheet on the bed already. So when the patient is transferred, you don't need to move him around, insert the sheet. When you're suspecting a bad trauma, you can already place it on the bed that he's going to be transferred on. So this is a really slick move. And then if there's pelvic tenderness, zip zap, you just put the binder at the good spot, you know, just remember that's a good move to do. And then we went through the basic technique to control bleeding. The shock is still going for traumatic amputation, like Catherine said. Put it on, you know, the leg is already off. And then on patient reassessment, so he's still intubated. There's good breath sounds now. Chest X-ray is done. ET tube is in a good position. He's picking up of his bleeding. There's still langulation deformity from the mangled leg. The FAST is negative for intra-abdominal bleeding. So you made the right diagnosis. It was the pelvis. It was the long bone. Tourniquet is applied for the bleeding. The pelvic binder is appropriately applied. So you saved his life. And ortho teams are on the way from the gym. Good. So key points for Mr. C. Recognize that the guy's in shock. Remember the floor and formor for hemorrhagic shock. Control the hemorrhage depending on what it is. Don't get me wrong. If it's an abdomen, I mean, you'll need to go to the OR, right? If it's the chest and it's a massive hemothorax, you'll need to go to the OR. But sometimes when it's a limb, a binder, a pelvis or a scalp, you can actually really help the patient by yourself in trauma bay, and it's really good to do. Begin resuscitation, remember 2 large IV bores, and then put some crystalloid. Don't hesitate to give MTP or if needed, obviously, or bloods. And that's it. Differentiate the different type of shocks. We said that hemorrhagic is the most common. Sometimes you'll get obstructive with tension pneumo or tamponade. Sometimes you'll get neurogenic shock with spinal cord injury, but often these are less, let's say, I would say critical. And pretty rarely you'll get septic shock. And cardiac contusion for cardiogenic, it's really rare as well. Okay. And that's it. So basically recap for your trauma rotation: stay calm, go sequentially, stay systematic, do your physical exam, and then with your physical exam, target some assessment, and then with the assessment and your diagnosis after the good treatment and surgery consultation. All right, guys, so that's pretty much it. I don't know if you have any questions. I know it's a lot, but if you stay systematic like this, you'll have a really good exam. And even more important than the exam is the patient you'll see in trauma. And trauma is really exciting, and you can really save a lot of lives and have a big impact on these trauma patients that are coming over. So please ask any question on anything during Surgical Foundation. I'm happy to help on anything.
I don't really have a question, but I just want to say thank you for that. That was very helpful.
Super.
Yeah, thanks, man.
Julian. All good, guys. I don't know how you guys work, but I can definitely send my talk if you want. If you want to use it, if you want to use the sequence, it's always the same thing. So trauma is, you just remember this and you'll be fine. And you can review the pleasure, Angela. You can review the techniques on by your side. You can read on the different technique, intubation, what is more relevant. Let's say somebody in ENT might want to review more the crike and the surgical airways, but I didn't think that this was super appropriate for everybody as it's really rare. Just focus on the A, B, C, D, E, and you'll be fine. And then target your intervention on your subspecialty and what will be useful for you guys. All right, so it's 5 o'clock. I think it's enough. Enjoy your evening, enjoy your boot camp, and see you around maybe in the hospital.